efficiency of care, safety of care, and I think complexities of healthcare sort of relate, to technology. And this is because, health IT has challenges. This is all recently, over the last 2 years, there are several hospitals in the US that have, bought systems. After a year or two, they've got frustrated with these electronic health record systems and, dumped them for another one. This is a national headline from a London newspaper, United Kingdom scrapping national health IT network, and it reads, after 9 years and 11.4 billion pounds, the British government is about to scrap its attempt to build a massive nationwide health IT network. So you can imagine that health IT is, of course, coming with a lot of challenges. There's also more challenges for us clinicians. Our efficiency drops down. The figures name 10%, but if you talk to clinicians, I'm sure they'll tell you more. The clinical decision support being used through electronic health record systems, the studies pretty much say that the outcomes are inconsistent. Some studies show some improvement, others do not. We, of course, want quality and safety to improve through use of electronic health records and health IT, but we're not getting those benefits yet. We've actually realized there's almost 22 types of errors that you can get through computerized provider order entry. We are now experiencing unexpected downtimes. We also had a recent instance in which 900 patients in UK actually got Viagra instead of Zyban because of an error in the pharmacy, medication mapping table. Of course, I'm sure that the patients were not too unhappy. So, in essence, we're looking at different outcomes than we think. We actually did a study on what VA did recently on their, so they had an implementation of intervention in which they delivered an automated notification of all pathology results all across the VA, all hospitals. So we actually did an evaluation of this intervention in 2 different hospitals across, one was in Houston, one was in Iowa. And we actually found, now the VA system is pretty homogeneous. We have we have the same electronic health record. Our systems, our policies are very sort of similar in many of sort of the broad levels. And so we actually did the intervention evaluation, and we found very surprising results. The same intervention through the same EHR in a very similar hospital in a different location had completely different outcomes. In one hospital, it made no difference. In another hospital, it actually had some positive influence. So you can see that we were really surprised. So is this all bad health IT is the question. And we will propose to you that to implement and use health IT, we need a multifaceted approach because the design, development, implementation, use, and evaluation of health IT is complex, and it's very prone to failure. And what we do need is a model to help us understand the relationship between all these complex dimensions. So today we're going to discuss with you the model. So the US team, Dean Siddig and I will actually discuss this multifaceted approach in detail, and then we will see how this applies in the Indian context in the second half of the panel. And then we'll get a perspective from both the public and the private sectors. So the agenda today is Dean's going to come and talk about the model. He's going to give you detail of this 8-step model. I'm going to tell you some US case studies of how we actually apply and use this model in our evaluation. And then we are going to do this discussion where our team from Max Health IT will come and give you their perspectives on their implementation and evaluation of the implementation. And then Kanav Kahol from Public Health Foundation will talk about this in the public health perspective. He'll give you the public health perspective. So Dean is up next.
Thank you, Hardeep. It's a really pleasure to be here today to see all of you and talk to you about some of the work that we've been doing in Houston, Texas. So this slide shows a little bit, one diagram of our model that we've been developing. And the idea with this model is to help people understand the immense socio-technical problems that these very complex and costly health information technology implementations entail. So I'll go into some of the issues. And so we look at this model as an 8-dimensional model. And so the first thing I'll talk about is what I call the hardware and software dimension. And when we think about this, this is the what everyone's familiar with. We've talked about handhelds and desktops and kiosks. We talked about some of the software that goes on it. And this hardware, first of all, must be capable of supporting all the required clinical activities. So many times we have software or hardware that's not entirely capable of solving that problem. And so, for example, your EHR should be able to calculate medication doses, transmit orders throughout your hospital or to pharmacies, and notify nurses of the orders that have been placed. So one of the things I think about when we're applying this model in the Indian context are some of the challenges and some of the facilitators that you have here in India. So, for example, I see one of the good things about hardware and software is this is something that can really be solved just with money. Now, if you've been in India like I have for a whole week and you know a lot about India, you'll know that money is one of the issues here. And so, whereas a lot of the other socio-technical problems are much more difficult to solve, maybe money is a hard one to solve as well, but this is something you just buy this stuff. It's available. There's lots of programmers in India and there's lots of hardware here. And so what a lot of people are working on now is trying to develop lower cost, less expensive forms of hardware, and you're going to hear more about that later today. And so the cell phone and these new Android tablets are becoming very, very expensive. So that may offer a really good opportunity. The next area of the model is what I'll call the content. And the content are these standard medical vocabularies that allow us to encode the findings. And all of these things we've heard about are critical if we want to do information systems work with decision support, because we have to be able to code the data so we can let the computer use it to help us care for the patients. It's difficult to get all the clinical knowledge that's required to create these specialty specific features and functions. And we'd like to have this be as evidence-based and carefully constructed and maintained, complete, error-free as possible. Now in the Indian context, there's an even more difficult challenge is that you have several large populations that speak different languages. And so we have a lot of issues of translating the content back and forth between different languages. Now the advantage of India has is there's so many people here that if you could figure out how to share this content, each person would only have to develop, or each hospital would only have to develop a small part of the content, and then we could share it across the country. Now, to do that requires a lot of standardization so we can translate it between the languages, and we can easily adopt the stuff that other people are developing. The particularly good thing about content is it's not like other physical resources where if I share with you, it decreases my ability to use it. With content, when I give you a copy, there's no reason why you can't use it just as fully as I can. So it requires a different mindset in terms of sharing, because in this case, the sharing really empowers the other people as opposed to reducing my utility of the content. So when I talk about content, one of the things I think about is an order set, for example. It helps a doctor to remember all the right things to order, the right doses, and it can really cut down on a lot of errors. And so these order sets can be developed for a lot of different conditions and procedures, and really greatly facilitate the data entry and the accuracy of it. The next part of the model is our user interface, and this is where the clinician or the patients are actually interacting with the computer system. This is what most people think of as a computer, and it must be able to allow clinicians to quickly grasp a complex situation, especially in a situation where patients, you're seeing 50 to 100 patients a day in an outpatient setting. These user interfaces have to be very easy to use. They have to be very quick to both understand the problem as well as enter the data that's required. It needs to have all the patient data right there, all the key patient data. And one of the challenges, I think, for India is going to be deciding what are the really important pieces of data. So clinicians are very good at developing these large, comprehensive data sets, but in this kind of an environment where there's so many people and so many patients and so much need, we're going to have to really focus down on what's really essential pieces of data and build our interfaces to support that. Probably the same user interfaces that are being used in the rich developing or rich countries that have lots of time and require a lot of documentation for our reimbursement purposes are not going to be the same ones we're going to use in India. We also have to think about the physical aspects of these systems in terms of the keyboards, the mice, or the touchscreen systems. And it'd be nice, I think, if we had some common user interface standards to help facilitate the learning process and reduce the time required when we go from system to system. Our next area is personnel. Clearly in India we have all the personnel we could possibly need. The problem is with the training of the personnel. And so we need people that are both trained on the computer aspects of this and the information technology, as well as on the medical aspects of this. And then we also need these people in the middle that I'll call these informaticians that can bridge that gap and help these engineers to talk to these clinicians. And so there's a tremendous training opportunity and a tremendous training challenge throughout the country. We've seen many examples here at the conference of computer-enabled medicine care and internet accessible education. I think that's going to be a key to learning this. It's sort of interesting. I've seen two students that are affiliated with my universities, Pramod Jacob, who was at the Oregon Health Sciences, and Ashish, who is at the University of Texas. And both of those students spent a lot of time learning in a remote internet-enabled environment. So I think that's going to be key for this personnel move. So I mentioned how these clinicians and technologists needs to work together. And if any of you are either of those people, you'll know that that's two different cultures. As much as the US and India are two different cultures, the difference between the programmers and the doctors is also two different cultures. In terms of our workflow and communication, this is key because you have a lot of challenges with the immense volume of patients and the need for their care. And so we have to figure out how to standardize these workflows and standardize the communication processes. And with that standardization, we have to do some simplification. And so I think that we're going to have to do a lot of careful workflow analysis and mostly find out what's really essential and try to limit the work that's done to stuff that's absolutely essential. Too many times we're doing things that someone else thinks we should be doing, and it's probably not directly related to what we're trying to do. And a lot of the errors that we make are when we have problems with getting these interventions to the right point in the workflow when we're not interrupting anyone. These interruptions can be a significant cost of errors. Our next part of the model is the organizational characteristics and the culture and the environment in which we work. And so the environment in India is very crowded. There's lots of people, there's waiting, there's not enough resources to go around. And so this culture of innovation that's just been, it's the most important thing I've seen at this conference. It seems like everyone's got a startup or they're in their own consulting company or they've just built an EMR in 90 days. This culture of innovation is just outstanding, and I think this is what's going to carry you through the next 5 to 10 years. And on top of that, you need some leadership support. You need your government to support you and to make the rules and regulations that are going to allow you to continue working on this. And so somehow we have to reduce the barriers to doing what needs to be done and figure out how to carefully review our existing policies and procedures to make sure they're not standing in the way. A lot of these policies and procedures were developed in a British colonial paper-based society, and we're not in that society anymore. We're in an internet age that's moving at the speed of light. So a lot of our policies and procedures are just not applicable anymore. The next step is our state, federal, and local rules and regulations, and a lot of these can put some barriers into us. So we need to reduce the costs of starting businesses. We need to make sure that we're not making regulations that are hindering our activities. We need to deal with our privacy issues, yet we need to allow people to do the work that needs to be done. And so I think that our state and federal and local government leaders can do a lot of work to help us figure out how to make this as efficient as possible. And the last area of the model is what we call our measurement and monitoring. And this is key because you have to measure. So we've heard so many people talk about evaluation, of measuring what's going on, trying to understand are these things working or not. So many times in technology we build it and we think that we're done because we've built it and we haven't really seen whether it's impacted patient care. And we've got to remember that we're not here to just build applications, we're here to improve patient care. That's been a huge challenge across the world. I don't think it's going to be any easier in India. And I think we've got to do this. Now, the hardest part of measuring is that until we measure, we can all think we're the best in the world. I'm the most beautiful person, I'm the strongest and the richest person in the room. Until we start to measure, and then we realize there's a few people that are stronger, smarter, and faster and more rich than I am. So that when you start to see the measurements, you realize where the room for improvement is. And sometimes that's difficult for people to deal with. And so that's what one of the hardest challenges we have. With that, I'll turn it back over to Hardeep to go into some details of how we've used this model in the US. And then we'll have Kanav and Divya also talk about how they've used it in India. Thank you so much. It's been a wonderful experience.
So we're going to try to hold a nice discussion at the end about the model and its application, but if anybody has a pressing question for Dean, we can take that now quickly, otherwise we can keep going. Okay.
Oh wait, Pramod, I couldn't stop you.
I think Dean, it's very specific to do with user interface. And
Use the mic.
I got a lot more. Okay.
I can hear you though. There's some old people up here older than me that can't hear either.
Hello. It's specifically to do with user interface, Dean. What happens is, for example, actually there is a state in India which, the state government has gone with an EMR system in the state government hospitals. It's in Tamil Nadu. What you find is, on an average, the numbers are so huge that probably a doctor sees a patient for about 2, maybe 3 minutes. Sometimes they don't even put a stat on the patient. Most of these patients probably have come with flu or influenza or some sort of, which actually can be treated quite easily. Now, as far as what is going into the computer, because of the load, they don't even put in a provisional diagnosis. They go straight to the treatment part of it and they choose an influenza package or one of those packages like Orasix like things. What can be done to improve that input situation? What is the future technology or what is presently there that we can do about improving that?
Yeah, so that's a really good question. I think the key is, the way I see the computer being useful is to try to offload a lot of that work. And so if I were in that clinic, I would have a computer system that had a whole bunch of pre-canned visit notes and treatment plans for the common illnesses, for tuberculosis I've heard about, and influenza, and diarrhea. And I would see the patient and I would say, that looks like influenza, and I'd send them off to a lesser skilled, lower paid person who would then take a history on that person using the computer and prescribe the treatment. And so I would let the doctor decide what's wrong and what needs to be done, and then I'd move the work down to lower paid, less skilled people to do that data entry. I don't think you should have your doctors typing in patient's height or weight or that they've got a cough. Someone else can do that just as well.
Yeah,
so I think that's the beauty of the way the user interface and the way the organization and the rules and regulations, all that has to work together, because right now we're not always allowed to do that. So that's the way this model is supposed to work, to help you think.
Very well said. I would just put it a little other way around. Instead of the doctor deciding, okay, he has this, he has that work should be pre-done and then brought to the doctor after that. That's a little difference in the approach, so that, and the problem actually what is happening in the Indian context, and at least what we know in India, unfortunately technology being expensive, the highest person in the hierarchy is given charge of it because of whatever, and frankly the entry and everything, if you give charge directly to the low people to manage everything, that's why, it's stated in your talk on the day before, that much more important is nursing informatics. So that has to be brought into the milieu. Most of the Indian systems that are being created are created finally after a lot of thinking, okay, we'll give it to the doctors.
Yes.
The doctors let them come at a later, they have already learned what they have learned in their life and they don't have time to learn new things now. So let the lower staff get into it, and they can incorporate the other people, and they're just there to make the decisions.
I agree. I think that's critical. Both India and the United States, we're both struggling with that.
Can you hold the rest of the questions till the end of the panel?
Yeah, just one, let me. This is not a question, it's more of, I want to make a point here. Like Dean was mentioning, we do have a meaningful use certified EHR running in the US. And we have a lot of experience that we gained out of the US. I just want to share with the audience one thing here. The problem, we work with the rural and the smaller hospitals in the US, places like Mississippi, Alabama and all that. The problem of the physicians or the clinicians not willing to enter data into the EHR is not a problem that we are going to face in India. It is so in very many places, even in the US.
Exactly. Yep, doesn't go away.
Okay. Thank you. Thank you. So I'm going to actually talk in the next 10-15 minutes about, our evaluation. When you actually put these systems in place and you're trying to improve care, what do we find and how we've actually found this model really useful in our work. So I'm going to discuss with you about 3 areas which I believe are important. One is communication of diagnostic test results, so that's the radiology lab. Second is computerized provider order entry prescriptions. And the third area is electronic referrals and how we've used this model in these 3 areas. So let's start with a problem that IT can help solve. So we all know that issues related with communication and coordination of test results and referrals, sort of the distributed outpatient setting where practitioners are practicing at various locations, the lab is located somewhere else, the imaging center somewhere else, is complex, and so are the subspecialists, and they're all communicating with each other. Technology helps us get information from point A to point B. So, hello, there's a thing that technology can help fix. So let's study that. So I'm going to show you what happens in the VA system when a radiologist or a lab sort of codes a test as normal or abnormal, and then that gets transmitted through what we call electronic health record alert or a notification, which goes directly from the lab or the radiologist in a sort of a standardized coded fashion to the electronic health record screen of the provider using it. So then the provider can actually see, okay, this is my patient, that was the location, and that's the test result. So, some of these are clearly abnormal, they're critical. For instance, if somebody has an abnormal shadow on their chest x-ray, that would be coded as an alert. And then, there's a lab, high potassium, positive pulse blood, all of these things will be coded and you can receive them. But as you can see, the providers also get a lot of other information because people are now using this as a communication tool so that they don't have to call the provider, interrupt them. So this is an asynchronous mode of communicating information to sort of the frontline providers. There are other things that come, information about referrals, the nurses send information through this view alert screen. So as you can see, it does start getting a little cluttered after a while because you do get notifications not just about abnormal labs, abnormal imaging, but you also start getting information from nurses and other things, whether you do or you don't want to hear about them. For instance, we've got an alert from a podiatry or prosthetics that your patient's got a diabetic shoe. We don't need to know this information, but the point is it does start getting cluttered. So communication involves not just getting information from point A to point B, but also taking action on the information. Unless you take action on the information, nothing will get done. So we actually looked at this in the VA system. We looked at about 1,000 of these view alerts. They were all abnormal imaging tests, okay? So they were abnormal chest x-rays, and so on and so forth. And we saw that about a third of the time, the providers don't click on the alert and acknowledge them. And we could imagine, sometimes the radiologist would just call them, that would be a reason, or the nurse would tell them, hey, the patient showed up, and I gave him his x-ray report, and this was the x-ray report. And that way I don't have to click on the alert. It's like an email inbox. So if you already know what the message is, you're not going to click on it. And so we looked at those, we looked at about 1,000, about 350 of these were unacknowledged. And we looked and saw, was there action on them or not? And we realized about, 45 out of those 350 did not have any follow-up actions. For instance, there was a chest x-ray that was abnormal, but there was no follow-up action on the alert, which told us that, some of these things are still getting lost to follow-up. even when we communicate electronically. So the point is, if we get information from point A to point B using technology, there still might not be an action on it at the end of the day. So we said, okay, well, let's look at both the times when their alerts are acknowledged by the doctors and unacknowledged. So we already knew that there was a problem when they did not acknowledge it. So if they didn't read that email message or the message of the alert, of course they might not take action, but we wanted to compare it to a cohort of alerts where we proved electronically that they read it. So this is the advantage of using technology. We can now measure these things. So we actually measured, we went into what's called the alert tracking file, and we pulled out all the alerts that were acknowledged by the doctors. All right, so they had read it. We had proof, electronic proof, a timestamp of when they read the alert. And then the other cohort was alerts that were not acknowledged. So we did this study. In almost 2,500 alerts, we included lab and imaging. And in both the cohorts, for lab and imaging, almost 7 to 8% of the time, even when the alert was acknowledged by the doctor, they did not take follow-up action at 30 days. So nothing got done. So we looked at, trying to find out reasons why this was happening. And so, we started digging deeper, and quickly we actually did a quantitative analysis. So in the VA system, you also get alerts to 2 providers. So if I'm the primary care doctor and I order the chest X-ray, the alert will not only go to me, if I find the subspecialist and order the chest X-ray, for instance, the alert will not only go to me, but it'll also go to the primary care doctor. So you can notify 2 people through this, view alert mechanism. So can anybody tell me what happens when you use a backup mechanism to notify 2 people of an abnormal test?
Nobody takes action.
Nobody takes action because each one thinks that the other one's going to take care of it. So we actually did an odds ratio. Our odds ratio was twice. If you send the alert to 2 people, you diffuse responsibility and nobody takes action on it. So I had to have my statistician do the analysis 3 times because I didn't believe it. And then I went back and looked at the notes that the research assistants were pulling out, and the doctors would say, that's not my patient, that's not my responsibility, I ordered the test on his behalf, you called him, I'm not going to take action on it. So anyway, talking about teamwork and responsibility, this is essentially what was going on. And this is exactly what will happen when we try to sort of diffuse responsibility in a technology-enabled healthcare system. So let's go digging deeper. When we started talking to the docs, well, they said we get too many of these. Remember the examples I gave you? So when people realize, here's a message, here's a way to get messages to the doctors, let's just flood them with messages. So remember the example I gave you about sort of the prosthetics department sending me an alert about a diabetic shoe. Do I really need to see that with my abnormal chest X-ray? That's exactly how I'm going to miss it. I'm going to miss these things when I get too many alerts. So this is actually a code. One of the issues is just sheer volume of alerts, and there's a number of alerts that in all honesty really you don't have any business seeing. Subsequent studies, we've done multiple studies on this, we've done surveys, and it all showed multiple barriers at multiple levels. And that's how the socio-technical model I was telling you about has been really useful. Because we've looked at software functionality, the docs would say, those alerts, I click on them, and they just disappear. I can't retrieve it. There's no way of tracking this information. If I get called out of the room, my nurse would tell me there's a sick patient, I would go, the CPRS would log out, the Vista system would log out, and I come back, I can't track that alert. Content, Dean talked about content. Look at the types of alerts we're getting. We don't need to be seeing all these alerts. Usability, you remember the window that I showed you? It was all monotonous looking, a whole lot of alerts. There was no sort of, highlights, there was no red flags. It just has a window, a small section saying high priority, low priority. So you can miss things because of a poor signal to noise ratio. Looking at the workflow, providers said, when I go out of office, it's hard for me to get alerts to the other person. Or when I go and visit for a week, all my, alerts, clutter up. So I need to try to get them to another person. There was actually, we found that as a risk factor. We also found providers didn't have knowledge, so simple sorting features. That view alert window that I showed you has a sorting feature, and providers were working in the VA system for years, but they did not know that you can sort through them. So there's clearly some knowledge and training issues that came out. And again, policies and procedures about training. So people would say, we never get training on these things. We go to these sessions for 4 hours. They talk about everything else but view alert notifications, even though they are so important and the crux of communication that occurs in a technology-enabled healthcare system. So let me give you a preview to the second example, which is CPO, is what I'm going to talk to you about. Anybody can read that first prescription? This is a real prescription, by the way. And the reason it's here is obviously there's not a good outcome. Anyway, take a guess. Any cardiologists in the room? Zendil. Just the first one. All right. So this is a real prescription. I think the point home is, we have got rid of this legibility problem through CPOE, and I'm going to show you an example of what CPOE can also do. But the whole point is this prescription was written as Isodil, but it was prescribed as Plendil by the pharmacist. This was many, many years ago, and actually the patient died. So through the computerized communication of prescriptions, we have tried to solve this problem. But look, when we evaluated CPOE, for instance, we also found some trouble. People think that CPOE was going to solve our medication error problems. Well, let me show you an example. So here is on the top structured text. Structured text shows 10 milligrams oral warfarin every day. Okay? Look what the doctor put in the free text. Take 7.5 milligrams Monday through Friday only. So if I'm a patient or the pharmacist prescribing this, if I read the free text comment entry, I'm going to think what? Well, should I take an additional 7.5 milligrams Monday through Friday? Should I only do 7.5 milligrams Monday through Friday? And so I would be actually confused. So we found this inconsistency between what's called the narrative text, which is the free text of CPOE, and the structured text, which is on the top. And these inconsistencies, we did a study actually, got about 532 scripts, and actually found 20% of these had potential. Of course, they didn't reach the patient because the pharmacy stopped it. The pharmacy actually either called the doctor or changed it themselves. And I actually heard that some of the pharmacists here don't call the doctors often. And I think that's, again, an organizational and culture issue that we're going to have to fix. So again, we had a problem with training. The doctors didn't know that there was a complex way, complex order entry system within CPOE. So, when we prescribe prednisone, we get a stapling dose. How do you get that into CPOE nicely? Well, there's actually a complex order entry template that allows you to do that. Most of the providers we talked to didn't know about that. Again, training issue. The last example is that of referrals. Transmission and tracking of referrals is finally possible, so we actually now know that information can get from point A to point B. Remember, point A to point B. We got the information from the primary care doc to the subspecialist. So we looked at that. What does the specialist do? And how do they communicate back and forth? About 6 to 7% of the time, again at 30 days, information is lost to follow up, even though people put it in the computer and send it the other way. When we looked at the communication back from the subspecialist to the primary care doctor, again, almost 7.5% of the time, information lost to follow up. So again, the point is, we've got information from point A to point B, but we're not getting the outcomes that we think we are. Why? Look at this. Marked differences between what the subspecialists want on the consult template and what the primary care doctors are willing to put in the content. So Dean talked a lot about content. They don't agree. They think, so the PCP says the subspecialist has access to the EMR. They should be able to go into the EMR to decide what to do next. Why should I give the whole history? So I showed on the first day, the urology consult template, which almost takes about 7.5 to 8 minutes to do if you start entering all the information they really need. So there was a lack of standardization, policies and procedures, where there was ambiguity on who's going to take follow-up. And again, we didn't see a lot of technology barriers. Okay, it was all about this organizational issues, culture, policies and procedures, and so on. Again, so this is sort of my final take-home point. We really need this eight-dimensional approach to understand and improve what we're doing with technology, because we can actually find this, all of these things interact with each other. So if you look at sort of hardware, software, you'll have to fix the disappearing alert that I told you about, but then again, that requires an organizational change, and we'll have to go to the central headquarters to get that done on a national scale. So all of these dimensions interact with each other, and the whole point is we all always think about all 8 of these in almost all of our projects that we do now. So with that, I'm actually going to take you one quick question, and then we'll turn it over to Vivek Sahi, who is the head of clinical transformation at Max, who's going to talk about EHR implementation.
Yeah.
Okay. Great. Vivek?
Hardeep, will you like to interact for a moment with any query or comment? No, I think we'll go at this. Okay, Dr. Gogia. Okay.
We wish we had more doctors out here to listen to you, and because, sure.
A small doubt for Dean, or maybe you may answer. Like in the sequential steps you have mentioned in this 8 slides of safe EMR, like regulatory framework and the rules and regulations which have to be formulated by the state, you put them in the end. So it looks like once they are formulated, then the software developers are aware that what kind of protocol they will follow, what standards and norms. So it is known from the beginning. They want to facilitate the development of national.
So it's actually not a graphical model at all. It's an interactive model, so you can start anywhere as long as you address all eight.
Okay, thank you.
Okay. Chawla.
Thank you all. This is a great opportunity. This is the longest title, but basically it means we've measured what we've implemented an EHR, and how to measure it was something very, very new to us, because of course we were new to EHR, and we took the help of the experts to learn how to measure it, and we did that over a few months. This study is done by a group of IT professionals, people who have knowledge of measuring, and also the head of internal medicine in our hospitals, because he was leading the initiative from the beginning, Dr. Sanjay Bedi. There are a lot of parties involved in the implementation. I might mention a few names, but there is no promotion or conflict of interest with anything. So if you get a few names which are brands or something like that, it is not meant to influence any further action. So some published statistics of EHR implementation. This is from a BBC report on the national NHS EHR implementation that they did. They saw some success. There is a reduction of medication errors, what is expected. They even went on to claim that there were 17% fewer preventable deaths. So with that rationale, we've taken this vision. It started out in 2008. I'll give you a brief background of our organization, our project. We are a group of hospitals based out of the National Capital Region, Max Healthcare. We started out as 8 hospitals, and now we've grown by 4 new ones. We've extended beyond our boundaries, and we've gone up to Bhatia, Mohali and Dehradun, so it's going to be North India rather than NCR now. This new development of new 4 hospitals has doubled our bed capacity to almost 1900 beds now. And the key thing is that all our hospitals are on a single instance of a HIS and an EMR. We've already been live with the HIS, which was the Hospital Information System evolving over the past 7 years in all hospitals. But the EMR implementation has been successfully completed in 4 of our hospitals, starting with Saket in Delhi, and also Shalimar Bagh in Delhi, and Bhatinda and Mohali in Punjab. So the volume of information and the single instance nature makes it pretty much the largest implementation of its kind in India. This is what we call it. We call it the Max E-Care, and this started with a vision. Some of the acronyms that we'll use are listed here, but I'm sure most of the audience are aware of this. Our vision was to have a patient-centric database, and we wanted to standardize our care processes. Now, standardization was the basis that we want to get it there, but not the all-encompassing vision. So there's other stuff. We wanted to have the easy accessibility to patient records and all clinical information. We wanted to capture a multidisciplinary patient record. We wanted to also implement something called a minimum data set, that anyone recording the information in the system should comply to something as a minimum. They have to put in this many minimum sets of data in the system. When we started out making the data set, it did not turn out to be minimum. So we had to re-envision ourselves and control the flying horses of our imagination to really make it minimum. So finally, we had a well-documented strategy on not just demographics, but also clinical details. It was a complete IT outsourcing. We chose World Vista as the product. It is an open source flavor of Vista, the VA system that is used in a large number of Veterans Affairs organizations, which has several open source flavors as well. and we integrated it to our own Max HIS. The rationale was that there will be potential reduction of medication errors. There was improved medication and management. There was accurate capture of information, reduction of duplication of services, access to more comprehensive picture of the way the health is moving around for the patient, and basically providing a continuity of care. External consultants were involved. We had people from the US, we had people from the UK. The way all of this was modeled, we also had people from India. So the external consultants have been involved not just during the implementation phase, but also after the implementation in the measurement phase. So some of them are representation from there. Process mapping was part of the thing that was pretty much the basis for how we started. When you start a new EHR implementation, the vision is that your patient's file is going to go on the computer, and that's as simple as that. So that's the vision which the doctors come to the audience. But the fact is that every process is going to be impacted. What was done on paper, which was a single file lying on the nursing station, would now be available on all computers. Impacts the process so widely that it causes a lot of risks. So what we did was we started with workshops. They went on for about 2 months. They happened about July 2011 to September 2011. And these workshops had a wall which had all the process maps laid on them, and we would call one department at a time, talk to them about the EHR vision, and talk to them about their processes and map it all up. And then we took on the challenge of matching these processes to future processes. The change of the processes because there was an electronic system coming in. And that was, again, a 2 months exercise. But between that, from doing the as-is processes, we understood that we had a lot of data which was already being used in our Max HIS. And we were using it in a certain way because we were a conglomerate of 8 hospitals, and there was some variety there. And the moment we were going to put it all on the computer on the same screens relevant to each other, we would see duplicates, or we would see a multitude of representing the same information by a different language. So it required a lot of data cleaning. It was not just users that were going to use it that were data cleaned. There was name of procedures they were required cleaning. There were name of tests that required cleaning. There were name of laboratory features that required cleaning. Even the titles that we give to our records. For example, initial inpatient file was called initial assessment, initial inpatient file, initial comprehensive analysis, depending on whichever department was using that terminology. But for the EHR, it had to have the one single terminology. So it's a lot of people coming on to agreement, and that's where our leadership helped us a lot. We've been supported big time by our leadership. I will talk about that a bit more. What we did was we went live over a phase, and we started off as a silent go live for our patient demographics. And there are more subsequent stage. About 2 months later, we did lab, radiology, pharmacy, and stabilized for that, not with the EHR running, but as a preparation for the EHR, and followed it up with CPOE and BCMA. BCMA is a new concept. It is the representation of an electronic version of a medication administration record, and it's called a closed loop medication administration, where the record of the order to the dispensing to the delivery to the nursing station and to the administration to the patient is on a single loop. What we did was we trained, and we trained more, and we trained more yet again, and we realized that we were training wrong, and we changed our training modules, and we trained yet again. So training was like big time. We've almost occupied 5 rooms in our hospital, 5 big enough rooms to hold 40 people. And in spite of the pressures for other people requiring the same rooms, we've been supported to continue to have those rooms, and we're continuing to train. And change management was something that went not about training at all. It was about calming people's nerves. You have to talk to people. You have to make sure that the fear and the anxiety you have from new things that are coming is controlled. Plus the fact that a lot of data entry would go on to people who are not used to data entry. There's a lot of change management still going on. We continue to go on. We did a big bang go live for our IT systems. 23rd July was the date, and we turned it on. First hospital to go on had the biggest brand, that was Saket, because everything went on going live, which was either going live for the entire organization or only for the hospital. have super users identified from our training program. Anyone who showed promise during our training program or had shown interest or ability was chosen as a super user. We decided to have about 120 super users initially, but we ended up having a fewer set because people do move on. So attrition is a big problem. Anyone who's good is likely to be sought out by other people. Change managers have been really helpful. Change managers are again a representation of our extension of calming people's nerves. They are there on the ground, working in the departments as parts of the department, but also contributing to change management. It's been 6 months since our go live, and now we're talking about a study that we did to measure what happened during these 6 months. We had a lot of stabilizing time in the first 2 months, hiccups galore on the technology front, also on the content front. Slowly and steadily we did stabilize, and now it's been a good ride. I'm able to take off from the hospital and talk to you is an ability which has happened over these months. So our study, it's a mixed method approach where we have been measuring and tracking the progress of EHR. The first measurement would be a quantitative one. We are taking 6 automated metrics, and we are extracting that from our MOMS database, which is the backbone of the EHR. The second one is an interview of 4 groups of representative users. These include senior consultants, junior consultants, floor mentors, and nursing supervisors. And then the content analysis of these interviews identifies the major themes on which we've worked with external consultants to do a fact-finding questionnaire and analyze a semi-quantitative data on the fact-finding questionnaire. Just a brief detail about barcode medical attestation, which I touched upon earlier. The nurse uses the computer to log herself in. That identifies the nurse. She scans the wristband of the patient, which is barcoded, to identify the patient. She scans the label on the drug, which was available, to identify the drug. And the system internally does a check. The checks are, for that period of time, which are the medications due? Is the barcode part of those medications? If it is not due at that time, it will alert the patient, the nurse. If it is the wrong barcode, it will alert the nurse. If it is the wrong dosage, it will alert the nurse. If it is the wrong time to be doing that, it will alert the nurse. But if it is required to do it at a wrong time, let's say the patient was to give an afternoon medicine and he was in the radiology department. So he came back maybe 3:30 or 4 o'clock. But the afternoon medication was missed and has to be administered. You can change the time frame on the BCMA and scan it, record it, and put a reason why it was given late. So anything that is done off the order, if overridden, can be recorded and justified. Now the first part of our study, this is metrics from the automated analysis. I'll briefly touch upon the structure of our EHR, not our EHR, EHR in general. It starts from clinical data and patient demographics. Basically, patient demographics is all that is captured in the registration of the patient at the front office. Everything that is related to the encounter information, whether he's an inpatient, whether he's an outpatient, that status. The fact that the patient has a problem becomes problems list. It's a terminology which is new to us. We've always called them differential diagnosis, provisional diagnosis, final diagnosis, but they can be grouped together as problems. Because a chronic problem would be a long-standing past history. Acute problem would be what he's represented ourselves with. So problems is the core structured data of what a problem patient has. It is coded with ICD codes, so it is also the diagnosis. The lab results are structured, the radiology information is structured as in orders and reports. The pharmacy orders and the way they were administered is structured, and it is all there. Whatever else is there as a non-structured text-based data is called a progress note. So progress notes could be a multitude of steps done by all sorts of people. It could be done by nurses, it could be done by dietitians, it could be done by physiotherapists, it could be done by residents on a daily, twice a day basis, it could be done by consults for any referrals being taken. It could be done by doctors who would do once a day review of all the previous progress notes and add their addendums. CPOE is the acronym you know all of you know is Centralized Physician Order Entry. So those are the record of the orders. Problems is that explained. Additionally, the nurses record a lot of structured data in form of vitals. The vitals include not just heart rate, pulse rate, temperature, blood pressure, pulse oximetry, oxygen saturation, but also input-output charts, which means all sorts of infusions that the patient is on, all sorts of outputs that the patient would be off, oral intake, Bride's tube intake, urine output, stool output, vomitus if any, cardiac parameters which are being taken down on a monitor next to the patient, dialysis parameters which could be done on a dialysis machine on the patient, ventilator parameters if the patient is on a ventilator. So there's a large number of vitals which are recorded, and the analysis was that the use of progress notes was 75%. The use of orders, CPOE, which is mandatory to take care of the patient in our inpatient, is 100%. Documentation, now this is from a policy that we have. We have a policy in the medical records department for our NMH and accreditation that every patient should have at least 2 progress notes, one in the morning and in the evening, recorded by the primary care team. That was a metric that we took. Of course, the progress notes were used by many more, but following and linking to this policy was done by fewer, 65%. The problem lists, the fact that a patient has a diagnosis, a structured entry, very few people, only 15%. The documentation of input-output charts, this is very important for taking care of the patient and done by nurses primarily. A high percent are doing it in the inpatient areas, 82%. However, critical care areas have a paper parallel process going on and the percentage goes down. They're not using it as much and critical as much as the IPD, but the calculation is near about the same, it's about 75%. A parallel pressure paper process is always a barrier for EHR uptake and it causes a lot of confusion. I'll talk a little bit more later. The use of BCMA by nurses is also taken as a measurement. The method I described is what will explain why this happens. The real-time entry of all the drug records is 41%. But after the fact, when the work is over, they can do it in the system and they go a little beyond 41% and bring it up to 78%. We are slowly improving on that. Now I'll talk briefly about the interviews. The interviews were more like a general feeling the person was getting, and I told you the group of people that we interviewed. And the results were that the younger doctors were more comfortable. The senior consultants were hesitant with new technology. And therefore had a low degree of adoption. But this was not across the board. There were a few older people who were very, very proficient, and there were a few younger lot who were just not in touch. So this is a statistics which is representing a feeling, but actually there are exceptions on both sides. There were typing issues with 28% who said that they were comfortable on a general interview. The EHR system's complexity was a main concern by participants, with Dr. Hadid pointing out content being cluttered. We've got comments from our doctors saying, I have no clue how to find the progress note because there are about 100 of them visible. There are methods to sort that data. They've not understood that. Training will go on. There are methods to sort out the notification, which Dr. Hadid pointed out. And our doctors are not even close to that because too much information on the electronic record is giving them a feeling of clutter, and they call it complex, complexity being a challenge. There is a perceived reduction in efficiency that, given the time I used to have and I used to function on a paper-based system, I was faster. This computer has taken away a lot of time, and generally speaking, the entire hospital's processes are slow. Most of the users who were reluctant and had to use it for 2 to 3 days finally became okay with it within 2 to 3 days and started perceiving the benefits. They reported high degree of comfort, and they kind of eventually divided this particular thing. Anyone who had used it for 2 to 3 days was an early adopter. Anyone who hadn't even tried was a resistor. There's a big difference between nurses and doctors how they use the system. Nurses are mandated to use the system, while doctors are never mandated but kind of forced in an indirect way. So 100% of the nurses had to use the system on day one and had to attend the training sessions. The doctors were hard pressed for time for training as well as day-to-day use. So many of the doctors could not attend training, however a large number did. But nurses 100% did. Ongoing support is required for these doctors because eventually they have to use the system, and if they miss the training, somebody still has to hold their hand. So we had to have that vision, and we're continuing to do that. To get there, I think the facilitators of the processes to get to this far The leadership role of Shabnam Singh is here is great. We have been under the wing of the leadership from the very beginning, and we've been protected through thick and thin. They have enforced policies and procedures, helped us guide the users to get to achieving the target, and brought this change. Clinical transformation and change management is a big supporter. You have to calm down people's nerves, you have to know the system, you have to know their processes, and you have to see the marriage of the process and the system and explain it to the end user. The user-friendly clinical templates, the fact that the system that we use allows us to custom build clinical templates on the fly is a huge advantage and a disadvantage. That means a lot of configuration activity is always pending. You have to still create a few more templates, but it gives us a tool to calm people's nerves. If you go and meet a person and he wants a certain requirement to be fulfilled and you're able to fulfill it using a flexible template, it gives you a mileage which will help him adopt more. We have easy accessibility of all patient records. That means across our patients, all patients are visible to everyone. Any location, if a doctor moves between 3 hospitals, he can connect to the same record. Any patient, anytime, whether the patient is in the emergency or the OPD or the IPD, you can. It's a very light system. The client is very responsive. You never get a slowing down of searches if you're doing a complex search. Whatever the system's capability of search fields is, it responds instantaneously. Another set of results. Now this we had worked closely with an external consultant with. We had 12 did you know type questions, and these were taken around to check whether they knew the system or not. It was a mix and match. 5 of these questions were generic, so most of them was equally answerable by doctors and nurses. The others were only specific to doctors. Nurses fared very well. They answered all the did you know type questions that they knew it. Doctors could not go beyond a certain level. The total number of was 2. Some people got up to 5, others got up to 10. But in spite of training and using on a daily basis, they did not know the system very well. And we did not have complex questions. Additionally, there were 18 specific fact-finding questions ranging from rate your own usage, comfort level, perceived improvements, perceived benefits, suggestions for improvement. And this is a complex results screen. The central column is where I've slotted the majority of the responses, and the right column is where some outliers have been mentioned. Usage of orders, 83% said it was high to very high. We know that our CPO usage is 100%, so the people who did not say yes to this are delegating the responsibility to someone else. A majority of the people are comfortable to use the system for viewing reports. Comfort and level of typing was a surprising result. Everyone said that I'm quite comfortable. Ease of use was with software. 78% says medium to high ease of use. There are other results, but I'll quickly go into other challenges and the analysis. Some other features that came out besides those results was that although CPOE was used 100% and the expectation was that we'll get a faster delivery because of CPOE, we did an analysis of how many stat orders were filled in time. The stat duration for drug delivery, if it is not a ward stock medication, if it's going to be supplied from the pharmacy, is 30 minutes. It's pretty strict rule, but it's followed. But it's met only 90% of the time. And as you know, there's no 80-20 rule in healthcare. If it's stat, it should be 100%. So this is one of the challenges where we have to improve. The things that don't reach on time, we have to look at that. There was an increase in overall discharge time after the HR implementation, and now it is stabilized. The initial increase was, of course, because we were using a parallel paper process. Half of the information on paper, half of the information on computer is a disaster. We've gone past this challenge now. This is the studies and early experience of the largest implementation of our kind. 4 facilities have gone live with a comprehensive EHR. The outcomes and the key takeaways that I want to talk about are several lessons have been learned. Patience and aggressive change management is the key. You can't let a person's aggressive resistance get you down. You have to be patient with every single individual and help them through this thick and thin. Whatever the problem may be, you have to help your users. Focus and support from leadership, biggest, most important thing. We've been under the support of leadership to get this far. Without our leaders, we wouldn't have gotten this far. People don't like to put in data. People like to review it. So whenever a EHR is rich in content and people have to review their records, they're very happy. Whenever someone has to put in the data, it's a big challenge. Benefits are perceived only by the ones who are more willing to use the system, and vice versa. Anyone who is not willing to use the system, never even tried to use the system, is always a resistor. So early adopters have benefited more from the laggards. The laggards have resisted most, or it could be the other way around. Aggressive support is required at least till the ratio tips in favor of adopters. We want to go beyond 60% of adopters. Until then, our aggressive support would continue, and before ramping down the support, we've got that in our minds. Thank you.
Thank you. I'm going to invite Shabnam Singh, who is the Dean of Nursing, Allied Health and Wellness Programs and a Senior Executive at MAX, to tell you sort of the leadership and the organizational change perspective of EHR. So everybody thinks, we'll just get technology, we'll put it in our system, but unless you have those leadership aspects and organizational change aspects in place, you can't get this right. Go ahead, Shabnam. Thank you.
I'll just take 2 minutes to share our experience in 10 years of this. This is the 8th time we've changed the vendor. So I think that should speak volumes to where we are and how you move. So anybody who's going to walk this mile, I'll have 2 bits of advice. One, you have to be a very brave heart. Okay? 2, you have to either arrange to have deep pockets, or you must have the money in the bank to be able to make this happen. This is no easy ride. Everybody thinks that the moment you adopt this, it's like, saying this is going to be the answer to all my problems. No, it is not. So when you want to adopt this, be very, very sure what is it that you want out of it. First, identify that for yourself. Then match it to the cost of the product that is lying out there. And third, realize the adoption of this, and I'm going to use an analogy, is very much like immigrating to a new country. For the people who are going to use this, it's a new language. Professor, it's not your boss saying you did something wrong. With nurses, full-time employees, if they don't use it, they're not going to get paid, right? And if you see the other portion where he said there was 100% compliance, and that was in where the orders were to be placed, whether it was for the pharmacy, whether it was for the diagnostics. Now, if your patient doesn't get the medicine, आगे तो गाड़ी जाएगी नहीं, उसका investigation नहीं होगा तो आगे गाड़ी जाएगी नहीं. So unless they filled it in, they couldn't get those things done. Thereby, you got the compliance. And that is where I call the carrot and stick policy. Lastly, please be patient. The day will come when this will be able to be adopted on a much larger scale. But let's not forget that the people who are using it at the top of the pyramid were never exposed to using computers while they were being trained. Neither in school and neither in college. As there is going to be tweaking of curriculum, introduction of computers, the advantages of using the system, both from an operational, safety, financial piece, you are going to get that momentum going. Lastly, I'd like to share, always look at new areas to introduce this. Our best adoption of this has been in our Bhatinda facility. That's a brand new facility. People are eager. The moment you go into a mature facility, be prepared for a huge amount of resistance. Lastly, when you start at the bottom with your paramedics, we all look at, teach the doctor, tell him to fill it in, things are going to happen. No. Start at the bottom. First empower your nurses, your front desk people, your administrators, then walk up. Because then what will happen is 75% of the stuff has already been done by a person A who is far more flexible in the mind, has been exposed to computers, has got the time, the energy to fill that complex thing so that where the keywords have to be punched in, the hugely burdened, time-strapped nurse and doctor can come in with those critical points. These would be the approaches that I would like to share with you. Thank you.
Thank you so much.
I think it is an excellent example of well-planned model, well implemented, and emphasis on one thing, you realize. Training. And then a vision of the leadership. Excellent this thing now, I think.
I'd like to invite our last speaker, Kanav Kahol from Public Health Foundation. Kanav is actually the division leader for affordable healthcare technologies, and he's going to talk to you about some exciting things that are going on at the Public Health Foundation of India, and how what is their vision in implementing and using, and their perspective in implementing and using health information technology.
Okay, I'm going to try and keep it short and sweet, and hopefully you guys can hear me. So my name is Kanav Kahol. I'm actually the division head for the Affordable Health Technologies at the Public Health Foundation of India. Public Health Foundation of India is a 6-year-old organization. We've been working on various facets of public health, and of course we've been doing around 80-odd projects using IT, many of them being pilot, but some of them actually going on to full scale. So I want to actually begin with this, which is the report that just came out around a month ago that has been getting a lot of press. And just recently, the PMO now has instructed the government or the Ministry of Health and Family Welfare to operationalize or present an operationalization plan for this particular report that we actually done. And one of the great parts about this is how do we do universal coverage. So the basic idea is that there will be a single payer, government will actually cover most of the primary, secondary, it's a public-private partnership. But I think the one that's most important is the recommendation 316.4 in it, which talks about establishing a health IT network and operationalizing it. So I think there's a huge amount of buy-in from the government on that particular level, and what we have to do is present to them an actual vision of where it would lie. So I would encourage you to go to phfi.org, download this report, and really check it out. And it's building on work done by a lot of folks actually in this room. So I'd like to acknowledge that and probably present you some facets of it. So again, sort of using Dean and Hardeep's model, let's talk a little bit about the hardware and software. And when we implement a national health IT model, what's actually going to happen? We clearly need mHealth solutions. I think the concept of mHealth is just mobile. I really am agnostic to whether it's going to be a kiosk, whether it's going to be a telephone, whether it's going to be a tablet. I think that's actually almost secondary to the fact that we need some type of mHealth solutions. We are going to need our hardware and software to have extended or long battery lives, and of course enable the non-physicians to deliver care with supervision and monitoring. That's going to be a major focus. I know Dr. Shabnam Singh was just here, and she's been working with us in the CII and forming the Health Sector Skills Council, where we're trying to actually enable allied health professionals to be able to deliver higher quality of care with of course physician supervision, and how do we empower them with technology. So this is actually one of the things we've been working on is a health tablet, also called the Swasthya Slate, where we've interfaced water quality meter, heart rate monitor, ECG as well as thermometer with an Android tablet, and it works with Akash. And I think there are multiple types of elements that are already available here, so I think it's important for us to realize that. From the purposes of content, what we've been looking at, of course, is the indigenized and local language support. One thing we've seen, at least from around 10, 15 pilot projects we've reviewed, that if you actually involve the final stakeholder in the creation of the content, you actually have more success. So I think what we need to do is leverage the power of social networks, leverage the power of co-creation with the guys. So I mean, more important, it's very interesting. If you look at the handbook for Ashas, they're not written by Ashas. But if you actually go ahead and train the Ashas and then you ask them to create something similar, it's very different. So we're really trying to talk about that particular thing. And you need support for empowerment of patients and healthcare workers. This is a very simple system that we had where you actually put an RFID code on top of an equipment. You can scan it with your phone, and then the phone actually takes you to either a pre-recorded video or a website that explains you how to use that device in the local language. So if you don't know how to use a baby warmer, fine. We can actually just scan the little code on the baby warmer and then use it, and get support in the local language. And the content in the local language is created actually by other sort of super users, if you may, that are able to move this forward. In terms of user interface, I think one of the things is use of semiotics and images is going to be very, very helpful. We do need to move towards text less or text minimal conversations, at least on the mobile platform. When we talk about ANMs, our also auxiliary nurse midwives, our ASHAs, our healthcare workers, actually, male multi-purpose workers using this, we will have to do that. And Dean talked about, in my conversations with him, talked about the fact that you need simplified questionnaires and sets. You cannot have questionnaires that last 30, 40 questions. You've got to reduce it down to 4 or 5. And there's one question in human-computer interaction. So my basic training as a computer scientist was in human-computer interaction, and there's a great term called affordance. And what that means is that there are multiple ways to get to the same goal. Now, how many ways do you have in Windows to open a file? Multiple, correct? And what you do is you use all of them. And for me to do research on which method is better to the goal is a moot point. So I would say, make your software work on a mobile, on a kiosk, on a conventional laptop. We need to now stop trying to get into issues that are, I think, as I said, I think it's a moot point. What we really need is multiple ways for people to use the EHR, multiple ways for people to use electronic health and make it successful. So I think one of the terms is affordance, the other big term is personalization, right? While I can personalize what my Yahoo page can look like, I can never personalize my EHR view. Now that's, I think, a huge waste, right? Just because there are basic systems like the Vista, which I really do like, but Vista doesn't allow personalization. So how can I actually ensure personalization of content? Every ASHA is different than every other ASHA. Every ANM is different, every doctor is different, every nurse is different. Maybe we need to allow for certain levels of personalization that will allow for this. Just examples of portals. This was actually mentioned in the report in terms of different kinds of portals that need to be supported by a national health IT network. So we do need an epidemiology, early warning system, messaging centers, and we're already starting to see things like that. And then I think one of the most important aspects is that as the private sector is gearing up in terms of providing personalized services, when I go to Lal Path Labs, I get a little number, I SMS that number to, another particular number that's given to me, and I get my test results on my phone, right? It's beautiful. In US, that would be a dream, but we're already doing it in this country. So why can't we actually extend it to a national level? I think it's going to be the most important thing. And if anybody wants these slides, just SMS, email me, and I'll be more than happy to send that to you. A little bit more about personnel. Okay, so this is one of the first. So I landed in India in July 2011. And one of the most important things that I think everybody in this room has heard is that, we don't even have electricity, and you talk about electronic medical record and all those great things about the fact that people don't know how to use cell phones, and nobody has cell phones, and the internet is expensive. Look, the fact is the internet went commercial in 1995, all right? And we in this country have been looking at 1995 is when we started hearing of TRAI. We've been really aware of technology. A lot of people use technology, but they might have a mediator. So most people actually do book railway tickets, but they book it through a booking agent who knows how to use the system. And that's the kind of model that India could also go and be perfect. I think as a community, we need to know that people born in 1994 are going to be 22 and working by the time they get to 2060. We've done a huge analysis that is now being presented to Lancet. It's in review that basically talks about that many of the barriers with technology literacy will actually start vanishing over the next 4 years. And I think it's important for us to really look at that. Our workforce is changing. The people who are earlier, the people who were decision makers had never used technology, but that demographic is changing too. Right? So we actually have decision makers who are going to be using technology, the actual implementers who are using technology and are aware of it. So it's an opportunity. The next 4 years are very critical for us. And I think it's important to realize that many of these are going to vanish. To give a case in point, the Health Sector Skills Council that the CII and PHFI are actually working on together is going to have training for allied health professionals, and each one of them actually contains 2 courses, Introduction to eHealth, and second one, Problem Solving through eHealth. And we take eHealth as the generic thing where EMR, EHR, everything is included. Okay. A little bit about the workflow and communication. This is one of the sort of sad stories about India, and I think many of you would have heard this, but just for the sake of rhetoric, I'll go with it. There was a woman in the Rangareddy district in Andhra Pradesh, and this is actually the Rangareddy district in Andhra Pradesh. I'm not going to get into the specifics just for the privacy's sake, but the woman started having some bleeding out of her vagina, goes to the nearest sub-health center, which is around 5 kilometers from her. The doc says, well, I think you're going to need some blood transfusion, go to the nearest primary healthcare center. The primary healthcare center nearest to her was 60 kilometers. So she goes on a bus, she gets to the primary healthcare center, which by that time her bleeding is pretty bad, but the primary healthcare center says, sorry, we don't actually have blood transfusion here, go back to the district hospital. And the district hospital originally was only 10 kilometers from her place. By the time she reaches district hospital, she's dead. Right? Now this is, the sad part is that many of us have heard stories like this in this room. And the worst part is that we actually sort of look at it and we go, what can the technology do about it? Well, a lot. If we actually have a database of where is the nearest blood bank, if we actually have a database of where is the nearest thing, or even simply giving our ASHAs and ANM a phone pre-programmed with numbers of the primary healthcare center, SHCs and district hospitals, so they can actually make intelligent decisions, is important. And that's what we call, sorry, it looks like the slide got changed. That's what we call as the public health decision support system. Make a database of the facilities, what are they actually offering, and then use that as a way of mapping your resources. And I think supply chain algorithms are becoming kind of interesting in how we do that. When people think of decision support systems, they think of clinical decision support systems. We are very interested in clinical decision support systems augmented with public health decision support systems, right? Because it's not just about whether I gave the wrong dosage, it's also about resource allocation. And that's going to be a beautiful thing. And actually there's some very interesting things. So I believe there's an NGO called Drishti, which is the India census partner, that's right now working with West Bengal to map out where the primary healthcare centers are, what are the facilities, how many beds are available in that, and that kind of database is going to become critical. So we are actually strongly lobbying right now to see if that can happen on a larger national level. Okay. Finally, the organizational, let's talk a little bit about the organizational characteristics. Now, we do need an organization that promotes use of health IT. Okay? Now, this is just an example of what we had. What was originally called Janch, but it got changed to NHMUA. I think NHMFUA is the organization in the report that essentially is now meant to look at the managerial aspects as well as promote health IT by giving out grants. Okay, so one of the things it's supposed to do is look at the fact that various organizations, both in the public and private, can adopt health IT. You give grants to these guys, but then these are actually, when you give out grants, you make them sign up for a regional exchange center, which is RHC, as well as look at the teleclinic at the primary healthcare center level. Now, we are talking about universal coverage, which means that there will be the central government that's going to pay for it, which means you can actually enforce this, right? And that's one of the most beautiful points that I hope IMI and everybody else gets behind, because we do have an opportunity here. A little bit about state and federal rules. We do need as I said, the single player will leverage for adoption. clearly need to define telemedicine. I know Dr. Bedi here has authored the telemedicine law, which we are trying, or the telemedicine law draft, and I think it's going to be interesting to see if that can actually be adopted, because we do need to give people credit for the fact they're doing telemedicine consults. But I have to say, I am very excited about the Tata Docomo giving a 9 rupees a minute call, or Airtel giving a 15 rupees a minute call. All these are great things. It was interesting, but I've had some access to what are the largest number of calls. And indeed, the largest number of calls into the telemedicine are the maternal and child care, right? Where these mothers are asking so-called quote-unquote stupid questions that they would rather not go to the doctor to, but they still need them answered, right? And that's a beautiful system. Diabetes is the second largest, where we are actually having teleconsults. So I think we'll have to focus on these particular areas and move that. There's one very interesting thing we do need to do in this country, which is privacy and security law. We actually do not have that. We don't have a HIPAA. We do need to make it, because probably not as top heavy as US, but we do need it. And then the final element is the right to connectivity. Now here's the idea behind it, which means there should be a certain portion of the spectrum that should be kept aside by the government for health as well as welfare communications, right? I think it's high time that we start lobbying with the government that the mHealth services we are using are exempt of payment, because we need, this is a national security question. If we cannot guarantee health to every citizen, we are not going to succeed. So there is a little bit of work on right to connectivity, where we're saying just take a certain portion of the bandwidth and let that be, that is used for, agricultural purposes, health purposes, and moving on. So I'd be very interested to hear what every one of you thinks about that. Finally, the monitoring piece, and we do need that monitoring financial and clinical measures is the key. There is some very interesting things that are already happening. So the first electronic medical record at the government level is the mother-child tracking system, right? So up till now, we've been great at aggregating data in this country. It's the disaggregation which is horrible, right? We know at the district level what happens, we know maybe at the sub-health center, but we don't know what's happening at an individual level. So the mother-child tracking system start doing that, where every mother is supposed to be enrolled, and every morning our Honorable Minister Ghulam Nabi Azad actually gets an SMS saying these are the number of mothers enrolled and these are the number of Ashas and ANMs. Getting it. It's a wonderful system made by NIC. But here's the interesting part. When you actually look at the data coming in from the immunization health information management system and mother-child tracking system, huge discrepancies, right? So if 95% of my mothers are being immunized and kids are being immunized, why am I having such high deaths? And that's the beauty of this particular system. We are able to catch that. So I think monitoring is going to be the key. But I do want to say one very important thing. Make reporting easy. Alright? When we do a pilot project, what happens is Asha or an ANM is supposed to record something on a mobile phone or a platform, but she's also supposed to record it on paper to satisfy the government reporting requirements. Right? That has to change. It's stupid. We can't allow for that. The second thing is, reporting is not the only or the most important feature of ICT. Up till now, as far as the government is concerned, that's what it's meant for. It's meant for reporting. More often than not, we just make a health information system and say, okay, it's reporting. But the final user, which in this case is an auxiliary nurse, midwife, or an ASHA or a doctor, what do they get out of it? Right? It's an important question. Why should a doctor spend 2 to 3 minutes entering pieces of information if they're not going to get something out of it? And that doesn't mean financial incentives. I believe that means empowering them with tools that lets them do their job. Okay? So we need to think about what is it that the doctors want in terms of the most optimal use of IT. Meaningful use of IT is not just about what the government says, it's about what the doctor also wants. So it's important to consider that. That's where I'd like to spend, and I'll be more than happy. I think we should just get into the panel now.
Yeah, please. Thanks. We are already overshooting the time, but still I think a couple of questions from the audience. Yes, Vivek.
Yeah, hi.
You talked about personalization of, could you just elaborate on that, please, Karan?
Sure. Hello? Yeah, here's the thing. Personalization of records is a personalization of the presentation of information is, I don't know what's going on, but the personalization of presentation of information has been shown to have a very positive impact on usage. Okay? When you actually go ahead and look at the fact that people on an Apple or a normal computer can personalize their desktop, they can personalize the kind of information they're going to see, that becomes a major driver for adoption. Right now what's happening is when the to give you a very simple example, you might have 6 tests that might show a certain condition, but every doctor will have their own preference, right? Right now the way it is EMR is just going to list all 6 of them and you have to search for what you like. On the other hand, if you actually make the one that they like or give the ability to make it bold, it's going to be much better. It's just when we do human-computer interaction, there are some fundamentals that we always stick to. Affordance and personalization are 2 big key drivers of what actually got computers from being, from being institutional machines to being personal machines. And we're completely missing out on that. So I think we need to focus a little bit on that. Of course, within the constraints of being safe and effective and the workflow optimizations that we want.
Okay, Dr.Sanjay Bedi?
Just very quickly.
I'll make a comment, rather a longer comment. I have seen all this, what you have said that we are all feeling that in coming 4 years, the barriers of literacy, early adoption, all these technophobia, they are going to disappear. They are disappearing very fast. And what my observation is, what the problems you have said, we are all working in our own silos. Well, you said that, I'll just give some examples. You said that the blood banks, if had it been known, AIDS Control Organization of India is also already working on that. They are already training everyone. Odisha is one state which has already made a website. You just click on that website and where is the particular blood group of your which you need, where is available, it's straight away, day to day it's updated and the whole work is going on all over India. Training of the blood banking charges are going on, but they are working in their own silo. Totally, they don't talk to anybody else and they are working in their own silo and they are controlling all the blood banks of India. So then secondly, a lot of medical colleges, they are making their own networks. And I'll just give you an example. Besides being the president of this association, I'm also in Medical Council of India committee, and a few as Secretary Computerization of Aiims Punjab, Aiims Haryana, and a few here and there Vice Chancellors Association. And everywhere I'm seeing that everyone is working in their own silos. And there are a lot of success stories. And day by day, this is a full software which has come, which can be easily downloaded on any mobile phone and questionnaire anybody can create and use it on a local basis for their own collection of data. But that is another silo. Disease surveillance people are using it, but they are not distributing it to others. So what is really needed now is that everyone should make a roadmap. So many solutions have become available and they have become affordable, and a lot of I'll give you an example. Last night,
will you please?
I will take just 15 seconds. Last night, a doctor from Patiala, he raised an issue that the different states in India, they are giving different criteria for CME credits. That was raised, that was forwarded to the Dr. Mohan Das, who is in Board of Governors of Medical Council of India. And just about 3 minutes ago, I have received a mail that has been forwarded, placed to the Board of Governors, and it will be placed in the next meeting. An ordinary doctor, now this is an issue which involves medical teachers and local doctors. So, but this is another silo. So, everything is now happening, it's happening fast, but the main challenge is connecting all the silos.
I think your point is well taken. Point well taken. Now, you see, we are last question for, okay, lady, just after, behind you.
I just want to say...
The mic, please, you take the mic.
Thank you so much for your presentation. I think everything that you...
Please speak into the mic.
Everything that you talked about in the last 10 minutes validated my years worth of work experience in India with a company called Dimagi, which is a mobile software company. And I just wanted to speak to a few points and give you comments based on my field experience.
How's Vikram?
He's great. But yeah, when you mentioned e-literacy, we work with Ashas, Anganwadis, and A&Ms across the country with some of India's most reputable NGOs. And within 1 to 2 hours, I can sit in front of a group of 40 Ashas and teach them how to type in Hindi on their mobile phones. Because our application has a feature, a case management feature, so they have to register pregnant women and newborn children. And after 3-4 months of them using the application and working with the NGO, sending the reports to the server, these Ashas, when I meet them, whether they're in Rajasthan, in Maharashtra, or in UP, they're so empowered. They want to learn more about technology. They ask me, teach me something else. What can I learn more? Add more modules to this application. We want to take it. We want to speak about HIV. We want to speak about reproductive health and sexual health with such a tool. And when you mentioned involving multimedia, that's the key that we learned very quickly. That a basic form on a mobile phone isn't as engaging. So with our application, we quickly made it so we display images and audio and videos as well through that while they're asking questions. So now, no longer does this form become just reporting. It's now a client engagement tool. And so beneficiaries in the village are coming to the ASHA now, trying to update the services that the ASHA has to offer because it's more engaging. So yeah, I totally...
Okay. Thank you. See, I think there is one more hand, but only thing is we are going to miss our tea then.
5 minutes, 2 minutes. Especially if you have closed loop medication going, hands off man. And if you have it across four organizations, you have not given us proof of concept that anybody in India can do this. A couple of quick questions. One is, I noticed you are using ICD 9. Is that true?
Yes, that's true.
And why not ICD 10?
Among the many challenges of setting up a new system with content, training and all that stuff, we saved on this challenge because the Vista application that we got came bundled with ICD 9. So although our country is working on ICD 10, we couldn't wait for Vista patches to be available before we went there. They would be available for download, I believe, at the end of 2012, which automatically upgrades us to ICD 10 seamlessly.
Do you have to pay anything for the ICD 10 licensing? Will you have to pay anything for the ICD 10 licensing? Maybe you don't know that. Okay. All right. Quick second question was, when you said the closed loop medication, is every tablet that is being given being barcoded, or is it just the tablets that will be given at 10 o'clock all being clustered together in a packet and barcoded?
Every single tablet in the inventory is being barcoded. Most of them are barcoded before reaching the hospital because they come through a central pharmacy. But many of them are also barcoded just short of dispensing before they leave the local pharmacy in the hospital.
Okay, thanks. Dr. Sanjay, can you come up for the mementos please fast? Because we are really late and the final of this thing is the mementos. Is Ashish Joshi here? Ashish is already left, we couldn't give him the mementos. Ashish, please come. The first memento goes for the first session talk which was missed out. Dr. Sanjay, please give us a memento to Ashish Joshi.
Yes, sir.
Ashish, please give a memento to Divya Chabra. Now the mementos for the other chairpersons. Dr. Sood, can you come up and give a memento to Hardeep?
I was about to click a photograph.
He wanted to take a picture of someone giving the momentum.
जो इनाम ले ना इनके जूम करके
Memento for Dean.
Thank you so much. Thank you.
For
Kunal.
I'll just take it.
No, yes. Yeah. And Dr. Bedi, please give the microphone.
nobody was. I think I'm kidding. Yeah. Today's a Sunday, so everyone has gone home. We have to have a very quick tea break. We are running late already. So 15 minutes, 10:40 Karanvir and.
Thank you, ladies and gentlemen.
And Ravi Kumar will be chairing the next session out here. We are again going to have the session in the split halls.
Okay, good morning, ladies and gentlemen. Thank you very much, Chairperson. So my topic of the morning is leveraging data analytics in healthcare, some success stories. So we had quite a few sessions on data analytics, data mining since the beginning of this conference, and today we are into day 3. So my aim of this presentation is that I should give you some actual case reports where the data analytics have been applied. And let's see if they are actually success stories or not. By way of introduction, there have been great breakthroughs in data capturing technologies, data standards, storage, health management information systems, and modeling and optimization sciences. Several healthcare organizations, particularly in private sector, have not only leveraged fact-based decision-making, but also created sustained competitive advantage from database analytics. So they have their business strategies, at least in part, around their analytic capabilities. So to put the things into perspective and we actually understand what we are talking about, it is important to understand what is the difference between data analytics, data mining, and business intelligence. So data analytics is the science of extensive use of data, statistical and quantitative analysis, explanatory and predictive model, and fact-based management to drive decisions and actions. And analytics is a subset of what has come to be called business intelligence, which is a set of technologies and processes that use data to understand and analyze business performance. Business analytics defines technology that uses data analysis to understand business issues, make smarter decisions, and to gain insight into your business. So basically, all has to begin with good data. So we had a session by Accenture yesterday, which emphasized the need of having a good, clean data, removing the outliers, having a good analytic culture, analytic talent in the organization. So if we have met these basics, then only we can proceed on further. So what's the difference between the two terms which are being used interchangeably? Data analytics is distinguished from data mining by the scope, purpose, and focus of the analysis. Data miners sort through huge data sets using sophisticated software to identify undiscovered and hidden patterns. And data analytics focuses on inference, the process of deriving a conclusion based solely on what is already known by researchers. So but what is the current status in most of the organizations world over? So the current status, I'll sum up with these two quotations. As a general rule, the most successful organization today is the one with the best information, because knowledge is power in 21st century. We all are drowned in data but starved of knowledge. So a lot of organizations are data rich, but they are information poor. That is, they are not able to leverage that data into useful and meaningful information to derive their business decisions. So what's the Indian scenario? As far as Indian healthcare organizations are concerned, we have firstly to meet the basic requirements of having a quality data. In India, most of the healthcare organizations are yet to embark on analytic journey, or they are still in early stages of it. They need to generate and compile good quality data by structured and reliable reports and returns. This data needs to be transformed into intelligence to guide decision and policy making. Availability of quality data on morbidity patterns and patient safety are grossly inadequate, and they can be utilized to design innovative health insurance products so that the penetration of insurance also increases. So currently most healthcare organizations are data poor, some are data rich but information poor. Very few could be said to be both data and information rich. So that's a sum up. So what does data analytics do in healthcare? Now it helps us in a practice of evidence-based medicine, adhering to online clinical protocols, as is being done by the Department of Veterans Affairs, which is the largest US healthcare system. It also enables early detection and diagnosis of emerging diseases, outbreak of epidemics, and prevention of fraudulent health insurance claims. These are some of the better known applications of data analytics. Then data mining is being used by hospitals to predict the average length of stay, which helps them better manage the patients, physicians, and the facilities. That is optimum utilization of overall resources. Another immensely useful application of data analytics is of predictive analytics, which means in forecasting and capacity management of the hospital. It means that capacity management is among the hospital's key challenges. When hospitals do not successfully manage their capacity assets, that is their beds, their physicians' time, etc., they suffer by revenue loss, operational inefficiency, and delays. So advanced analytics can impact the way the hospitals manage their capacity and other processes by enabling forecasting and scheduling for the immediate and long-term future. So this is one of the major applications of predictive data analytics. Now let's start with our public health information system. NRHM also got a web portal, and it has got an ITH, wherein the health statistics information portal, it's a web-based management information system that facilitates speedy and efficient flow of information from periphery to centers. Tools for advanced data analysis, reporting, monitoring, evaluation and program management, more efficient public health planning and forecasting for service provisioning, emergency preparedness, resource mobilization. So the basic objective of this analytics tool is to have data for action. Yesterday we had a presentation by Dr. Karanvir Singh, who apprised us of the Sir Gangaram Hospital initiative, which is a pioneer in health informatics and has been using data mining software called SpeedMiner. And they are able to achieve an effective business intelligence tool which helps in data analytics and real-time monitoring of KPIs, query handling, and serves as a quality dashboard through the various data collated over a period of time under specific heads. Another application which is being used by another chain of corporate hospitals is tracking infection control through data. Each of the hospitals in Apollo group tracks infection control parameters periodically, and these are benchmarked with standards and variations, and values are thoroughly analyzed. Periodically, clinical studies on infection control, pathogens, and other related areas are also carried out. So this feature is called ACE 25, that is Apollo Clinical Excellence Initiative, where key quality parameters of each hospital are entered on an online dashboard, scored and reviewed by the highest leadership of the group each month. So these are some of the basic applications of data analytics, that is in compiling data for action and then developing quality dashboards to evaluate the performance of the organization. Then another initiative has been by Johns Hopkins Institute, which has been replicated by so many other hospitals. It's called Comprehensive Unit-Based Safety Program, which lets hospitals identify safety concerns, learn about successful approaches, develop and initiate solutions, and perform regular safety assessments based on data analytics. Now, another application is called Health Map, which has got its own website. What it does is that it scouts the various sources, the tweets, and the other social networking sites and collates and processes their data to predict outbreak of epidemic in any part of the world. So the health map is immensely useful, which has been able to, in fact, predict outbreak of cholera much before it was publicly declared by the health authorities in Haiti. So health map is one such innovation that is a freely accessible automated electronic data mining project for monitoring, organizing and visualizing reports of global disease outbreaks according to geography, time and infectious disease agent. So this has been in operation since 2006 and has been developed by the physicians of Harvard Medical School. It requires data from a variety of freely available electronic media sources and to obtain a comprehensive view of the current global state of infectious diseases. Thus, Health Map is a public website bringing together disparate data sources to achieve a unified view of current global state of infectious diseases. Then another application...
5 minutes more, which includes the question answer time.
Okay. Another application is how the UK NHS is using data analytics for allocation of funds. So how can they maximize the allocated efficiency by the dispersion of optimal way the funds can be distributed. Then another application of data analytics have been used in tuberculosis drug allocation in Manila. And other example which some of you would be quite familiar with is the BioSense program. BioSense is a real-time clinical connections program in US which connects several hospitals, and if there's any case of infectious disease, that is, the information comes on the this network, and they are able to anticipate outbreak of any act of bioterrorism or outbreak of any epidemic. Index case can be known. So imagine how useful it would have been had there been such a system in place, say in case of outbreak of SARS or any flu or any such epidemic. So there is no panic amongst the population. So other application which has been used in about data analytics in healthcare is the Bayes theorem to develop decision tree. So if a group of medical professionals are constructing to get into private practice, there will be various risks and pros and cons and what could be the benefits of that practice. So based on the probability of the outcome, they can construct a decision tree to help analyze the problem. So to conclude, I would like to say that data analytics focuses on inference, the process of driving a conclusion based solely on scientific knowledge and facts, and not on experience and the intuition of the policy makers. More recently, the data has been increasingly used by healthcare organizations as a part of business intelligence to make strategic decisions and choices and to gain competitive advantage in market. So today, analytics strategy is viewed as a key engine of a dynamic capability of an organization. Indian healthcare organizations need to generate quality data first and then analyze this for strategic decisions and research. So I would like to conclude by saying the difficulty lies not so much in developing new ideas in IT as in escaping from old ones. If you are not riding the wave of change, then you find yourself beneath it. Thank you very much for your patience.
Thank you, Dr. Sood, Group Captain Sood. So, any questions?
Analytic tool, you can you have given beautiful examples of, you know, how business analysis is being drawn out of the data. Is there any instance where a specific analytical tool has been utilized?
Yes, this one example I gave of Sir Gangaram Hospital. They are using a software, a speed miner, to do data mining and to extract useful information from the wealth of data. So similarly, these tools could be in form of some mathematical models, optimization tools, or they could be the statistical analytic tools, or they could be some IT systems which sit over your whole lot of repository of data and are able to extract the meaningful information which will help you taking smarter decisions.
SpeedMiner is not HIS. SpeedMiner is a pure business analysis tool. It does nothing else, just business analysis. It sits on top of another software, sucks in data from there, analyzes it, gives you analytical results. Yes, Vivek?
Just to refer to Dr. Bedi. Dr. Bedi, there are various different OLAP tools, we call them OLAP tools, which are specifically for reporting. But before that, we need to do the extraction, the transformation and the loading of the data, because based on the KPIs that you have for what you want the reports, the data may be in different various sources, and those specific data fields would need to be pulled out. So for that you need a separate thing called an ETL tool. I can discuss the rest with you later. Thank you.
Okay, we are behind time. So if any more questions are there, I'm sure Captain Sood will be willing to answer them offline. Can I now request Saurabh Bhatia to please give his talk on reducing EMR implementation costs and improving adoption using e-learning for training and change management. So, thank you.
Good afternoon, everybody, and thanks, Dr. Karanvir. And I am also thankful to IIT. Now, usually in such conferences, you will find a lot of papers who talk about the strategy and who talk at a 60,000 feet view about how to implement, how to go about, and there are lots of how-tos vis-a-vis the HIS, the EMR, and the hospital implementation. I have just taken a very small area, so I am really going into the microscopic vision here. We are drilling down to a lower level, and we'll see how we handle training in a particular way of implementation, how it reduced the costs. Somewhere I also feel that the medical informatics is new in India, and a lot of conferences we talk about high-level strategies, and once we start talking about microscopic strategies, that also shows that we have begun to mature in our view and in our implementation of HISs and medical informatics by and large. Now, going live after a successful implementation of HIS in a big hospital is the beginning of a problem. Usually, most of us tend to end the story at so-and-so was implemented. It's not really like a Cinderella story where they lived happily ever after, believe me. The problems actually begin once the system has been put in. And the adoption rate of EMRs is dismal. It's as low as 33%. In this presentation, I'm using a personal experience of two quaternary care hospitals. One was Greenfield and one was a functional hospital. In both the hospitals, I have clubbed them because the parameters were roughly similar. The bed strength was around 900 at the time of implementation, to be shot up to about 1600. The workforce was huge, roughly similar in both hospitals. We'll see the numbers later. The EMR was being introduced for the first time. Both the hospitals were not unaware of computerization, but at the same time, EMR is a different problem. And the clinical adoption was suspect even before implementation. The leadership in both the hospitals was somewhat suspect. They was not very sure how the EMR would be adopted. The number of personnel to be trained in each hospital after the EMR had been put in was something to the tune of 2,400 nurses, 300 in-house doctors, 600 visiting doctors in the Brownfield hospital, but a similar figure was expected in the Greenfield Hospital as well, being of the similar size, and additional staff about 600 employees comprising of pharmacy, storekeepers, front office, quality, secretaries, and the clerical staff. So in total, we were expected to train about 4,000 people. One in a hospital that was becoming live, Greenfield, and another one which was going live. Which was already live. The training logistics which we had worked out to train people on the EMR were that at least 8 hours of individual training was required. The traditional method is to train them, like you take 20 people, make them sit in a room, you show them something on a projector, ask them to do some practice. This is the common traditional method by which training is imparted, typically in a working organization. We had decided that there will be 4 periods of 2 hours each, because it was not really feasible to give continuous training for 8 hours, or even to break it up into 2 trainings of 4 hours each. Because then the turnaround, the sessions where there were doubts, it was not enough for people. Now we came across a lot of problems with this. I'm going to show you 4 slides of the problem statement itself, and which talks volumes about the kind of problems we were facing. The first problem was a different set of employees needed different combination of module trainings. So it's not really so simple that we divide 4,000 people into 20 groups each. It's not a mathematical group. We need to group people according to the role they play in the hospital and train them according to that role. The second problem was batch making because of shift of duties. A hospital typically works round the clock and people are on duty round the clock. Even if they are on the date when we are doing the planning. So with the HR, if we do the planning on a certain date and certain people are put in a particular block of training, it is not necessary that after 1 month when their turn comes, they are still doing the work in the same shift of duty. They might have changed night duty, they might have changed to evening duty, and that makes it impossible for them to attend the same block in which they had been nominated. The next problem was the 2,400 nurses, they could not be spared during duty hours. So when they are on duty, they cannot come to the training rooms for taking training. So somewhere they had to take training apart from working, which was a little difficult. They showed resistance. In the Greenfield Hospital, the nurses were being hired at a very rapid pace. Every day we were hiring nurses to the range of 24 to 30 because the hospital had to go live. And at this rate, the HR was not really able to put their act together. They were not able to give us the plans, they were not able to give us projections. So we didn't even know how many people we are going to train on which day. All the doctors were not able to attend because the schedules were haywire. There was of course the emergency, there was of course the OT schedules, and batches of 20 for doctors was next to impossible. The visiting doctors, they came only once in a while to the hospital. They sometimes had a definite schedule, sometimes they did not have a definite schedule. They came on request. Forcing them to attend a pre-planned session was impossible. And there were to the tune of 600 visiting doctors. And the next thing was the infrastructure. Both the hospitals had one computer lab. One had 6, one had 8 computers. This was not adequate. We needed 20. They were ready to upgrade, so they were not showing resistance to buy more computers. But space and the availability of network was still a constraint, and there was a lot of channel in the hospital to be cleared to even purchase a single computer. So all this was somewhere delaying the trainings. Lastly, the nurses had a huge attrition rate. The nurse group by itself had an attrition rate of 25%, which meant every year 600 new nurses were coming on board, which practically means that there will be 2 to 3 new nursing trainees coming in on every working day. This kind of trickle, it's very difficult to control and train. For the remaining course, the attrition was about 8%, which meant about 125 new trainees every year. The total training was expected for 200 batches. Somewhere we expected that there will be a spillover. Every training batch will not have 20 people each. So there will be a spillover of about 250 batches, 2,000 classroom hours, which meant practically 10 months of training. Now for any hospital doing implementation, 10 months of full day trainings is practically very difficult. The time frame was unacceptable. Time frame alone could defeat the adoption program. The adoption has to be done within certain timelines, and if the training is going on for 10 months, the adoption cannot happen. And it will be seen as an implementation failure, a common story. The cost was too high. I have done the numbers there, the paper is also available for all the people who have joined the conference, and we can do the mathematics there. But overall, you can see the total cost was working out to be about 53 lakhs for the entire training over a period of 10 to 11 months. This overall problem was too huge to be overcome by a small or a conventional method. So we were expected to finish the training in a reasonable time frame, commensurate with the implementation plan. So implementation was being done by the technical team at a certain pace, and if we did not match pace by training people to use that implementation, everything implemented will not be used and it will be seen as a failure. We had to bring down the cost because almost half a crore for training was not feasible. And we had to ensure that employees, whether they are onboarded or they are old, they were all able to make the hospital functional. You cannot really have an EMR which is fully functional and have untrained people who are not able to use it. And as a result, the hospital is not having any real functionality online. So we changed our approach. Instead of conventional training, we adopted a mixed approach. The approach was synchronous and asynchronous training. Synchronous would be in a classroom, while as asynchronous training would be training being taken online. We implemented an enterprise training portal, which behaves like a website. This is an online learning management system. It was possible to access this material from within the hospital. Implement on them that you have to learn the system, and most of them are not even given a login. So overall, the success was moderate. I would say 200 people started using it, but from the EMR parlance, the way HIS systems have succeeded in past, I would still call it a success because the system was being utilized in the hospitals. Thank you.
Thank you, sir. This is actually a very true representation of what happens in almost all hospitals when they start these massive projects. Training is the big issue. The only additional thing I would like to add is that even after you have trained them, we didn't do training the way he did. This is a very good method. Managed to do it in 45 days. We trained them over a period of 3 months. The problem was that the first lot had completely forgotten everything by the time they went live. But what was surprising is even the latest lot had forgotten everything by the time they went live, even though they finished the training 5 days early. So one thing really made all the difference. We got a small software called Net Support. Many similar softwares. You put them across your LAN, so we had about 600 nodes. And we could actually take over someone's desktop and we could guide them, tell them where to click. So the actual training happened within the first 5 days after go live. The actual practical training, although all of them had been trained for hours and hours. And they had that sense of confidence that if there is any problem, even if it's on a live situation, support was just one phone call away. They used to ring up and on the phone, we used to take over their desktop, we used to click for them, tell them, next time they would be able to do on their own. So that one training in a live situation actually was better than 2 hours of training on a simulated situation. So that's one software that really helped us go live. Now, any questions, please?
Yes. Saurabh, I think it was a wonderful talk and you covered an area which is very critical in the EHR implementation. I just want to make a small statement here. We have got experience in implementing EHRs in hospitals in the US. And obviously the targets were not 900 bed hospital. We were but the first hospital where we went, it was in the rural areas in the US, and we were surprised the nurses who couldn't even hold a mouse. The training was the toughest part of the implementation. But we learned quickly, and by some very creative ideas, our total sign-on to going live in a hospital we were able to bring down to under 30 days. Today my team in the US says they are so confident that they can bring down from the time signing of a contract to going live under 15 days. So that's how training can make a change in implementation of EHR. I think it's a very good talk.
Thank you.
Yeah, like you said, like you had this assessment after trainings. So were there pass-fail kind of scenarios, and who didn't do well in those assessments? Were they still allowed to start using system, or they were asked to train them?
Okay, so the assessments that we had built, they were there's a way of building assessments where you can either have adaptive assessments, or you can simply have a pass-fail scenario. So we made that in certain areas the doctor has to score 80% marks to get a pass certificate. If he does not get a pass certificate, he is not allowed to go ahead in the learning management system. So it did not use that you have failed and you are barred from doing this and that. It simply used to keep them to keep attempting more. So they could take a quiz, and if they fail in that achieving 75%, it used to tell them that you have not qualified. And at the same time, they could also take the graph from the questionnaire, where they could see the weaker areas. They could work on that, and usually taking a second attempt in which they would clear. As luck would have it, by and large, almost everybody cleared in one go. There were a lot of people who cleared in 2 attempts. I don't remember much who could not clear in 2 attempts, and for some people, it was overridden by the management. Okay, they have scored 60%, they are not able to clear, but they are not willing to take a second attempt. They are too senior, so give them an override. So that also had happened.
And was there a recognition of this assessment outside these hospitals?
No, this was within the system.
So, like, I come from like IT industry, and I do solution for advanced healthcare. So, like in our IT industry, certifications from central agencies like MP and all. So, in healthcare, is there those?
No, there wasn't any certification for that, because that would again take a lot of.
But it can be like at conceptual level, there can be sort of. Yeah,
it can be adapted eventually with some kind of backing from some academic institutions.
Right.
But at that point in time, no, it did not take a certification.
Thank you, sir. Because of shortage of time, we'll have to cut down the questions. We now go to the next talk by Dr. Praveen Srivastava. Thank you. On hospital information systems and integrated approach for better patient care and generation of EMR, electronic health records. Praveen Srivastava, not here? Okay, I think we'll go next to Dr. Arindam Basu. Okay. This talk is on perceived benefits of hospital information system and EMR by end users, a survey done at a government hospital.
Good afternoon to everyone. Good afternoon, Chair, and good afternoon to all. Today I have got a privilege to explain my study done on a government hospital about perceived benefits of hospital information system and EMR by end users. First of all, I would like to thank IMI for selecting this paper and allowing me to present my study in front of the audience, in front of the delegates from organization. Before going on to this, when I was listening to Dr. Bhatia's talk, I was thinking that my study would rather help others to know that what all things happen after the implementation of an EHR or HIS system. This is a typical government hospital scenario where there is an HIS, there is an EMR and other information systems, ICT system which has been implemented for the last 1.5 years. Basically, we all know that what's the role of ICT in healthcare. Everyone thinks that the doctors, most of the clinical staff think that there is a ICT will always, take place of the doctors and the nurses in the hospital. But majorly the role of ICT is to just support them for their day-to-day activity. And there, typically, why ICT system is being more in focus nowadays, because we have lots and lots of data. The operational data is lots and lots of operational data is there, and we have to get the valid information for our innovations and all the stuff, and to get knowledge, not for the providers but for the hospital, and also this knowledge will help the population as a whole. So, what are different studies describe about ICT systems? The ICT implementation is an organizational process. As discussed earlier also, that ICT system implementation is not a one-day task. It takes months and months, sometimes years to get implemented, and a typical HIS or a EMR system. So, what are the substantial potential that a HIS or an EMR system brings theoretically, that to improve patient safety, to increase organizational efficiency, increase patient satisfaction. But what is the wrong perception in all the major healthcare organizations is that ICT overcomes the role of people involved and the patient is hindered. What are the classes to determine the success of ICT system? Basically, all the literature which I have covered up, it talks majorly about three classes to determine the success. The first is the user attitude and perception, the use of the system itself. The 80-20 rule here signifies that 80% of the requirements of the hospital or the healthcare provider should be taken care of by the ICT system implemented. If 80% of the requirements is not being taken care of, then the users will not be willing to use this system again and again for their operational work. And user performance with the system, as said earlier also, that the acceptance and like the test taken up by the people so that they can go forward with the ICT system implementation. My study basically deals with the user attitudes and perception after the implementation of the EHR system. What's the literature behind the study? Like there are some literatures that find out that basically the user perception using EHR is that it increases patient as well as the user satisfaction. One of the studies says that there were 80% of the acceptance rate out of 191 respondents in the survey. One of the surveys also says that the hospital information system, 57.7% of the users were satisfied. Now, what are the type of perceived benefits that I have covered up here? One is the direct benefits, like it reduces medical errors, it reduces paperwork. Indirect benefits like improves quality of care, improve access to data. Strategic benefits improve patient safety, improve organizational image, etc. Now, objective behind the study, the major objectives were to study the perception of the hospital staff towards the ICT system and to study the kind of problems faced by the staff of the hospital after the implementation of the ICT systems. The government hospital is located in Delhi. It's a 152 inpatient beds, 30 casualty and 26 ICU beds, 9 departments, presently has an HIS for administrative purpose and EMR for the clinical purposes. The ICT system is working more than 1.5 years. ICT systems, ICT applications used in that hospital, open source EMR and a lab module integrated with it, packs from GE Centricity, telemedicine center, access and biometric control, hospital information system which constitutes of models like patient registration, patient appointment system, billing module, surgery module, and inventory management system, and the computerized MLC report from the EHR template. The methodology used here is simple random sampling. Study was conducted in the month of May 2011. It was a questionnaire-based study having 13 questions, and it was some observations were also done. The definition of the sample here is the respondent should be either a user of a HIS or an EMR application. So the major focus was done on nurses and the physician. Some of the non-clinical staff was also taken. The limitations to the study are less number of respondents, as it was sent to 100 people the questionnaire, but it came out to be 52 respondents backed up with the survey. And open-ended questions were given so that we can get a holistic view of the people. Now, taking about the results of the study, the first is the number of respondents. There were 30 nurses, 13 physicians and 9 other non-clinical staff. And about the experiences, less than 6 months, 20 people, and 1 to 3 years, 16 people. They were the major people who took part in that survey. Now, one of the questions was that IT importance for the hospital, and the best part of is that most of the clinical staff says that the IT is very important and important for any hospital support work. So, the study also tells that it takes some time for the users to know that whether the ICT systems are good for the hospital or not. Next is finding HIS or EMR. As in the previous slides I have said that one of the implementation success is that the HIS or the EMR should be 80% fulfilling the requirements. And this one of the questions is that how do you find HIS or EMR? And most of the people are saying that it's very easy to work with that HIS or EMR. Now what's the average time spent into the application? More than 3 hours, 10 people said that they are spending more than 3 hours. And less than 30 minutes, most of them were nurses. 20 out of 25 respondents were nurses. When it was asked that why they are using the system less than 30 minutes, it was concluded that they have, first of all, they have to maintain both the paper records and the electronic records as per the government rules, and they are so habitual about the system that they know that which data is to be filled where. So it takes hardly 5 minutes to fill up the data, like for vitals for any patient or for any billing or for any nursing notes. They take only 2 to 3 minutes. So total the time taken by the nurses was less than 30 minutes. So improvement about after the implementation, more than 80% of the people says that there is a improvement, little bit of improvement or satisfactory improvement of their hospital or their work after the implementation of the EHR or the HIS system. Now, what are the major issues they face? Sometimes after the implementation, focus more on the usage of the ICT system, but sometimes we forgot to take the problems or the issues that they might be facing up. So major issues they were facing were of the process issues and the technology. The first one was the computer application getting hanged. Application takes longer time to open, less support from the vendor, and lesser GUIs in the application. And the process issues were manual and electronic record is to be maintained, which is still, I think, most of the hospitals are facing this problem that due to legalities from the government of India, they have to maintain both electronic as well as manual records. But the best part that I have gone through the study is all the 52 respondents, the average rating to this software, both HIS or EMR, is 7 out of 10. So it's more than, it can be stated that it's a good EMR or HIS system that they are using. That's why the rating is so much high. The benefits perceived by them, like more easy follow-ups, visit in OPD, reduction in turnaround time, reduction in medical errors, and PACS and EMR faster decisions, increase patient safety, patient satisfaction, employees are more accountable. This was actually an open-ended question, so it was a rather a holistic view of every nurse, doctor, or a non-clinical staff in their benefits perceived. Now, what are the conclusions? Sometimes we are so focused for the people that we sometimes forget that the technology and process also plays a vital role for any achievement or any success for any ICT implementation.
Dr. Basu, you have 5 minutes including question answer.
So last slide. So for achieving this, sometimes we forget that the processes and the technology is to be updated, is to be changed for the people to adopt more the system. If sometimes we are so much involved in changing the mindset of the people that even the smaller changes in processes and the technology leads them to adopt the system rather than changing their mindset. So recommendation, regular monthly assessment and updation of the technology used. Vendor support is a must until and unless the whole hospital accepts the system and use them without any support from the vendor. Process changes like manual records, and I show this discussion to this dais that we should have manual records or not, or we should, if the electronic records should be kept liable, should be kept legal by the Indian government. Staff should be aware of the interfaces. The major problem that they are facing, that the people who are using HIS, they were not knowing the functionality, what the HIS will do with the EMR. And the people using with the EMR, they were not knowing what the HIS will be doing in the interfaces with the EMR. So they were totally, either they were blaming each other or technology. Rather than blaming each other, we can, what the training schedule can be done like this, like whatever the HIS people are being trained, they should give a glimpse about the EMR also, so that they know what all work they have to do, are directly or indirectly involved with the EMR and vice versa. People are more important assets for any ICT implement system, but process and technology also plays a significant role for success. Thank you.
Any questions? Very nice talk, Anil. I would like to just add one more point to this, that the attitude of adoption also depends on one major thing, and this I'm coming from. I did a review of literature of nursing informatics for 8 hospitals. And one major point was that how the nurses work with the clinical patient and when do they do the recording. Unfortunately, most of the systems as yet do not support a lot of point of care devices. So the doctors and nurses are resorted to coming back to a nursing station or to the doctor's table and then recording what they record, which is very different from how we actually do the process in the hospitals, where they just put a mark or a notation on the case sheet itself. So this does increase the time of the doctor and the nurse spent on each patient, which makes them see it as less efficient systems.
So that's why the main, that's a process issue. If we can change something in the process and the technology itself, sometimes it will lead to more adoption rather than changing the people mindset again and again, like training them again and again. Only slightest changes in the processes and the technology will lead to more adoption.
Actually, there are 2 ways this has been addressed. One is with mobile devices and one is with mobile laptops on wheels, computer on wheels, cows. Mobile devices was started long back, but they never got on because of the small size. And in fact, I remember reading a couple of studies on US-based hospitals where they had been using them for 5 years. And towards the end, I think about some 10 or 15% of the doctors were using it for medical use, and the rest were using it just for their personal use because of the size. But computer on wheels is actually a success story. You make the whole hospital Wi-Fi, and that takes your entry to the point of care. Max Hospital has already done it. We are also in the process of doing pilot studies. But what I would have liked to see in this research is, this feedback paper, is to see the specific type of problems that they faced, rather than saying that who's happy, who's not happy. So if you look at the EMR, for instance, what are the specific issues in the EMR, and so that others can avoid that?
Yeah, the basic problem that they faced in EMR is like EMR is that open source that they are having. So majorly the problems were like the templates that they were getting there, like for any assessment by the doctors or by the nurses, they were having more textual formats rather than the drop downs that we can make, like drop downs or some GUIs in the EMR, the template, which will, like for example, let's say the temperature is 100 degree Fahrenheit. So the doctor has to type it, like 100 degree Fahrenheit, the whole word. What they can do is, if the temperature is higher than 100 degree Fahrenheit, they can have a GUI placed there and they can click that. And that will help them out that, to reduce that time and for more clinical adoption. For HIS, that they were having problems like the registration or some other, like for queue management or anything, they were having 2 pages of registration forms. That can be cut down into 1. They were having some irrelevant information required, like for example, one is the country you are staying, and the same question again it comes, what's your present address? So if your permanent address is this, and you can just add like, is it same or is it different? So they can have a click on that, is it same, then again the form has not to be filled again. The DEO has to fill it again, the same things. What he does is he copies and then pastes it out. So that's a shortcut he has produced. But what we can do is just give him click, like if it is same, just click it and you can complete your registration form. That's the major problem that they are facing.
So did you give this feedback to the original hospital? And
yes, we have given it and they are working on it. And they have EMR, they have still some problems because it's an open source. They can't change it that much, but the HIS, they have changed it.
Any other questions?
You must be just describe the EMR that is used. And secondly, is it OPD and IP? When I mean describe, was it just progress notes or does it include order entry and results?
The EMR used is the Vista open source EMR. And they were not having any ordering system as such because they were not having any pharmacy. They were just ordering the lab as was integrated with the lab module of Vista. So they were only having the lab ordering system with them. And
your findings are very different from what other findings are there for productivity. And the reason, that's why I wanted to get a little more detail of the EMR. A fully functional EMR, it is very unusual to find a finding like this, where there's so much of positivity, especially among physicians.
The physicians only, they were using, like they were filling the notes and the progress notes, the clinical notes, and they were just giving the lab orders. And obviously they don't have any like pharmacy within themselves, so they were not even doing the pharmacy orders also.
Yeah, actually, I have visited this hospital and I was surprised at how much input the clinicians are giving. They are writing down all the events that occurred, they are coding all the diagnosis, and when you look at the patient history, at least the ones that were shown to me, it is really good. You have full details of what is happening day by day. But that's probably because they have a huge number of residents. It's nearly like a 2 patient to 1 resident ratio based on the number of patients they get in per day and the number of residents that they have, because this is a teaching hospital. Thank you, Arindam. Now, has Dr. Praveen Srivastava come? No. We can have a next talk by Aman Rana and Anil Kuthiala. And that is on significance of a meticulous change management strategy and successful implementation of an HIS.
Good afternoon, ladies and gentlemen. I am Dr. Aman Rana, and I'll be presenting a study on change management. Change management is something which has been talked about a lot in this conference, and honestly speaking, I won't be telling you something new, but yes, I'll be telling you something with another perspective. I'll be primarily focusing on people's aspect and how a personalized strategy is important and may lead to a success, will surely lead to success of implementation of a health management information system. Now, talking about healthcare information system, in simple words, it's a software which is used by an organization to take care, to track and to manage the health status of the workforce of that organization. It's in today's world, it's probably in vogue because of something called as corporate social responsibility, where the organizations are primarily focusing on the health status of the workforce. That's because there's a shift in the mindset of the organizations that workforce is no more an expenditure but rather an asset. They want to track the health status of the workforce because if they have a healthy workforce, they will definitely be more productive and reach their endeavors faster. They also use healthcare information system to detect underlying occupational hazards, especially in the sectors which are dealing with certain professions which induce health hazards in the workforce. They also want to assess the success of any kind of health intervention that they have implemented in their organization recently, and of course Mediclaims which utilize most of the workforce time and investments are easily handled with the help of healthcare information systems. Now, talking about the flip side of the same coin, for employees, they give a sense of security that the people who are hiring them, for whom they are working, that organization is concerned about their health. They also are helped because all the information about their health is at one place, and hence the chances of medical negligence at the need of hour reduces. Now, a little about the background of my study. This study was done in a notable public organization. Now, let me tell you that this organization has nothing to do with either the health sector or the IT sector. So it's like kind of a third party to this health IT stream. And the software which we studied was Employee Health Management System, which this organization has bought 2 years back, but due to some reasons they had failed to get the maximum out of it, and this software was rather like vestigial in that organization from past 2 years. The objectives of this study was to understand the knowledge and attitude of employees towards this software, to find out the reasons why this EHMS failed in that organization, and to put forward an operational framework for successful adoption of EHMS, then evaluate the success of how well our interventions have fared in the organization, and in the last, we thought of providing suitable recommendations to that organization so that the EHMS continues to be adopted even after our study is concluded. It's a quantitative study and we involved 353 employees of that organization. We did not do any kind of sampling method. All the employees which we got involved in the study, we included them in the study, so it was a kind of convenient sampling. And we referred to the primary as well as secondary data as well, because we referred to the medical records that the organization held for the employees who were admitted in the past and had suffered some kind of health problems. The tools that we used for this study were questionnaires, focus group discussions and personal interviews. These tools varied from cadre to cadre of the employees. At the onset of the study, when we actually landed up in the organization, out of 353 employees, only 5 people somewhere exactly knew what EHMS is all about. And as a matter of fact, all these 5 people were the administrators who were responsible to launch this software in the organization and make it a success. There were 2 things, self-declaration forms and PHEs, that is periodic health records, PHRs. Now self-declaration forms had a minimum amount of health data that was to be provided by the individual, like your height, your weight, your blood group, hemoglobin level, minimal data which all of us know. And PHR kind of involved the detailed health records, including your pathological reports, microbiological reports, etc. So out of 353, only 12 had filled up their self-declaration forms, and no one at all had filled up PHR forms. Now PHR was supposed to be filled up by a personnel who was deputed for this work specially, but these PHR details had to be provided by the employee himself. 85 people had somewhere heard of the term EHMS but didn't know what it is all about, and 251 people were not even aware of this word EHMS. There were 2 in-house doctors who were giving consultations to the employees within the organization during the working hours, and when we talked to them, they were kind of reluctant to use EHMS. They thought that it's very technical and they are not that savvy to use that software, and it was time consuming also. This is a pictorial representation of the pre-implementation health status, intervention health status, and as you can see that 71% had not even heard of EHMS. Now when we analyze the barriers of what could have prevented the adoption of EHMS in this organization, there were 3 kinds of barriers. First, the technical barriers, because the software was working on a LAN, so at times the LAN was not working, people were not able to download the files, and the pages were not opening faster. Secondly was the perception of EHMS. This was a public organization, so people were like in a typical public sector side that, okay, this is very technical, we cannot do it, we have a lot of other works to do. Then the basic human nature to resist change. Something new was coming up and they were happy doing the conventional stuff, so they were not very open to adopt this new technology that was coming up. When we talk about the change, as just now Arindam talked about, that process, technology and people are the 3 things that get affected. When we involve new technology, the process, the workflows that are existing in the organization change, which affect the people and their professional lives. So, as I said, I'll focus on the people aspect. Harvard Business Review on Change, written by Mr. John P. Cotter, talks about 8 steps of transformation of organization, and I'm sure most of you already know about these 8 steps. I'll just brief it about you. The first one is creating a sense of urgency that yes, you have to bring about this change and there are no second thoughts about it. Second is powerful guiding coalition should be formed, which will act as a inducer of this change, creating a vision. All of us should know what we want after this change has been implemented, communicating this vision to the people with whom we are interacting with, then empowering others to act on this vision. This is a very important step, planning for and creating short-term wins. In celebrating short-term wins, you have to actually create short-term wins, because at the end of the whole story boils down to keeping the workforce motivated. So unless and until you don't have short-term wins, your workforce will not be motivated, and you have to keep the same level of motivation perennial throughout the project. Seventh is consolidating improvements, consolidating these short-term wins, and then producing still more change, because only when you consolidate these short-term wins, you will be gaining that last grand victory. And last, institutionalizing new approaches, because when you start working on a project, you'll come across various contingencies, and you need to plan and replan and modify your plan of action. So this was a framework which we came up with before taking action in that organization. Step one was to identify stakeholders and key players. That's kind of forming the guiding coalition. Second, studying the existing barriers in consultation with stakeholders, because these are stakeholders who actually know what's going wrong in that organization. So we asked them what they thought is actually the barrier to this adoption of this software. Designing and discussing the operational strategy with key players. Based on this framework, we came up with the operational strategy, which I'll discuss with you in the second slide. Next slide. Now, fourth step was performing interventions. We organized mass orientation for the employees. Then streamlining workflows. The workflows were modulated and modified according to the new technologies that we were bringing about. Then bring about transition by implementing HMIS. Evaluating the progress and change that is induced, because time and again we had to evaluate how well we are faring on the set targets. Communicating results and reports to the stakeholders. And last was monitor for continuous adoption of HMIS by the management and staff. This is one step which we could not deal with because we had the specific time allotted in that organization. This is which we left on the organization to make sure that the change has been perennially accepted and still being followed.
You have 5 minutes more.
So interventions, as I said, according to the framework, we followed this kind of operation strategy. We oriented them, we passed on a broadcast about EHMS, we collected their forms, entered PHE reports, and analyzed the health status, and then presented presented the latest records in the organization meeting. Post-intervention status, once we had done all the orientation programs and consulted all the employees and talked to them, the status was that all the 353 employees were aware, they knew what EHMS is all about. 226 had given self-declaration forms, 26 people have given PHE and examination status reports, and the doctors who were not ready to use the software were actually using the software. They were motivated, trained, and they were prescribing the drugs which were dispensed through the pharmacy module of the software. They were using this and giving consultation through this module. A graphical representation of post-implementation status. The right side diagram shows cadre-wise, management staff, non-management and labor, how will be fared in these various segments, and you can see that we were more successful in non-management staff section. We were able to get more self-declaration forms from the non-management section. As I said, cadre-wise response, 90 out of 124 people in non-management section gave their self-declarations. Now when we assessed our change management process, we realized that 64% of staff entered self-declaration forms. And we admit that only 7% people filled up their PHR forms, and that shows that in spite of creating awareness, there is still a lot to do, which we could not do because of lack of time and authority as well. But the organizations can definitely do more by providing some visual fringe benefits to the employees and making them aware, talking more about PHR, significance of PHR, and enhancing health-seeking behavior in the organization. There were certain privacy and confidentiality issues which were again an obstacle in our endeavor. Now the recommendations we gave to this organization were that they need one change management champion who will be kind of captain to this change management ship. All the sections like administration, staff, doctors need to work in in harmony with each other and share a good rapport, because then only they will be working coherently. The team should be equal mix of juniors and seniors, because seniors will provide the experience and they'll share their experience, and the juniors will provide the zeal and enthusiasm that will be needed during this change management task. And periodic review of every 6 months has to be done. Now, last but not the least, there are certain points to be remembered which I am sharing with you, because when we underwent this study, we held this study, we realized that change management is not an event which will happen overnight and next morning you'll be seeing that yes, change has taken place. It's a process which will continue even when your study, when your project is over, that will keep on continuing till you reach your best. And then the employee should be involved in this kind of endeavor from the day one, because when you give them a full-fledged, mature product to be accepted, they find it really difficult. When you give them this product in the initial stage, they'll be having a sense of responsibility and belonging to this product, and they'll feel involved. So it's a responsibility of top management to assure that the workforce stays motivated throughout, and that will be done by creating short-term wins. The leaders who will propagate the change, that's as we call user champions, they should share a very good rapport with people. People should trust them, then only they trust their convictions. And the employees' expectations from the product should be kept minimal. They should not expect some miracles to happen once the product is in place. And the last point is, it is essential to retain the change, as it is as important to bring the change. Because a change stays a change only when it retains. If it's lost, then it was not a change actually. Thank you for your patient listening.
Thank you. Any questions? If there are no questions, then we will go to the next talk, which is by Dr. Bhatia on business analytics on the fly for healthcare enterprise using the cloud model. Following this, there is one more talk which is not listed, which was originally in the next hall, but we have moved it over here. So this is the second last talk.
Thank you, Dr. Karanvir. I'm happy that he's chairing this talk, because he's the one who is pioneering in the field of business intelligence in the country. This is on business analytics in the fly for healthcare enterprises using the cloud model. I'm Indrajit Bhattacharya. I belong to International Institute of Health Management Research, and we are implementing a postgraduate course in healthcare IT. For those of you who have attended this Health 2.0 session, this was the message which was given in the beginning, that healthcare today is receiving a tsunami of data, and we are data rich but care poor. The challenge today is transforming data to actionable care. And the roadblock to e-health data is fragmented and changes over time. This is why hospital and healthcare management says data can be turned to intelligence that can make difference between ineffective and timely care versus costly and ineffective and even inappropriate action. Another one by IDC Health Insights, as providers increasingly get information and more clinical data into their repositories from the use of new technologies coming as a result of the meaningful user requirements. They're coming up with new applications for analytics. And what is analytics across the valued healthcare ecosystem? That is, for the healthcare providers, it gives clinical quality initiatives and reporting, operational efficiencies, financial performance management, and pay for performance initiatives. In the pharmaceutical and the biotech sector, it gives comparative effectiveness, adaptive trials to support personalized medicine, consumer and physician engagement and decision support. In the academic and medical centers, it gives translational, clinical and comparative effectiveness research, collaborative and extra enterprise research, and in public health area, it gives disease surveillance, comparative effectiveness and clinical utility studies. What is BI once again? Business intelligence tools for hospitals such as those offered by SAS, which is leading in the BI area, to develop scorecards to track quality indicators across EHR systems. Advantages are not limited to tune up bed and inventory utilization and staffing, provide predictive trends for cost-effective decision making, access to actionable knowledge that can measurably demonstrate ROI helping in driving operational efficiencies and optimizing patient care. The limitation is cost of procurement and maintenance. There is the Sectoral Innovation Committee report of health systems which has just come out, and it says that the SAS which has been procured for the NRHM MIS reports is underutilized. So what is business analytics on SAS? A delivery model for business intelligence in which applications are typically deployed outside the company's firewall at a hosted location and accessed by end user with a secure internet connection. Providers, the vendors provide it either on subscription or pay-as-you-go model. This is the basic architecture, BI architecture on the cloud, which has the processing power and source data storage on IaaS, which is infrastructure as a service. The data warehouse sits on the platform as a service, which is PaaS. And the software as a service has aspects such as data warehousing tools, OLAP, data mining, reporting, and business performance management. The characteristics of a good BI are the structured or should be able to handle both structured or unstructured data, data quality and integration, for converting data into a format readable by the database, healthcare data warehouse for storing data used by BI, and healthcare business intelligence and analytics engine, and a healthcare portal for display of data for the healthcare customers. The business intelligence on SaaS has advantages such as self-service, real-time analysis, on-demand ad hoc analysis, high-performance exploration functionality with pluggability, scalability, and security, and pay per use. Limitation is obviously bandwidth constraints. This is the model on business intelligence on demand. On the left-hand side, we have the client environment, which has Microsoft Microdynamics, Oracle DBMS, SAP as an ERP, and other data sources, which goes to the business analytics on the cloud with extract, transform, and load from the cloud vendor, data warehouse, and then goes to reporting, analysis, and data mining. This is the typical SaaS model for BI in the healthcare, which has the hospital information systems, ERPs, legacy systems, as well as documents, which are loaded to the cloud, which has collection and consolidation of data. It goes to turns into information by analysis and reporting, and then to knowledge and real-time self-service on demand, and then decisions for improvement in patient care. What are the benefits of adopting cloud computing? Are the supply chain management and capacity building, the scalable infrastructure, collaboration with companies offering similar services, accessing insurance details, and fast and easy access of health records, standard integration, report generation using dashboards and KPIs, and increased customer service quality. What are the benefits which we derive from having this is visibility, that is different faces of the same data can be seen, granularity, which is deep dive into the data, availability, accessing any data, anytime and anywhere, simplicity, can be used very well by non-technical person as well, and integration and externalization, which is cut and slice, ship out the chunk, integrate, cube it, and show it selectively. What if analysis, that is the change effect, that what would happen if something could occur, and forecast and trend analysis, which is predictive tool. The key differentiators are on-demand self-service analytics, large data handling, performance, data load and view update strategy, enterprise scalability, flexibility in analysis, externalization and implementation of time and cost. These are some screenshots which have been shown from the business intelligence used on the cloud. This is a screenshot of the diabetes outcome records, which has the age groups and the details shown. This one is another screenshot of how the National Quality Forum reports can be done, taken out, derived from the business intelligence tool. Another screenshot of billing of different specialty with bed types and surgery details. Another screenshot of the billing of different specialty with on the right hand side you have the various departments and the average bill amount. So what are the evidence-based benefits, which has been told yesterday by Dr. Jack Lee, implemented it at Taipei Medical University. The benefits of clouds is 50 to 70% IT cost reduction, 30% in reduction of power saving, efficient and effective resource allocation. And Dr. Karanvir Singh, who has adopted BI benefits, is definitely the to demonstrate benefits of HIS and EMR adoption. As Dr. Saurav pointed out, the reality of EMR adoption in India is dismal, and Dr. Karanvir Singh says that the cloud tool, the BI tool has been used to incentivize use of EMR in India. So privacy enhanced, it can change the future delivery of healthcare IT delivery. The conclusion, options for analytics for monitoring and evaluation of health indicators in MDG goals, NCD, as well as the environmental and climatic studies, and implementing BI in the cloud would help in reducing capital investments and tremendously improve in decision making by healthcare as well as public health organizations, reduce cost of care and improve healthcare outcomes. Thank you very much.
Any questions?
Yes, Vivek, Dr. Vivek.
Can we go back to the slide where you showed us the
This one or the previous one?
No, previous one where you showed.
Okay, yeah,
this one. Okay. Now, first and foremost, my understanding would be: are you talking about one having a particular provider on the cloud, or are you talking about having multiple providers on the cloud?
No, there are one provider of the cloud. That's what I'm talking about. I will obviously not name several providers are currently operating who provide these services on the cloud.
No.
Yeah, I'm talking about, there's only one provider which provides.
One, so you're talking basically of the private cloud here?
We are talking about private cloud here. Yeah, but Dr. Jackley said that even the public cloud can be used if you encrypt the data while you host it and then decrypt it while you
Right. Okay. Now, in all of this, where does the data model sit?
Data model, it can be on the cloud itself, that is with the vendor, and it can be at the premises as well. Both models are available. That the tool can reside at the premises or the data can be hosted as well. It's both model is possible.
Okay. And finally, I think the biggest issue that, with regards to security.
Yeah, that's what, so my last point was that, so if privacy is more enhanced on the public cloud, then if we take care of the security issues, then this model will have more recipient of adoption.
Okay, thanks.
Thanks, Indrajit. It's a wonderful presentation. I just wanted to share a concern with the forum in general. It's just like you buy a car to go to the office, but then when the car is there in the garage, we also develop the urge to go for a long drive. Similarly, in IT, when we start seeing a lot of data being accumulated in one place, we also develop the urge to start torturing it to find out what it can tell us. But the one thing which we usually tend to overlook, and there's a strong tendency about it, is to not look at the importance of continuum of care and just the basic help it brings in the patient care when the data is available simply. And the data mining or the business intelligence and all these reports may not be available. But these days there's a trend among the vendors to show the business intelligence tools, the reports they can show to the administrators of the hospitals in cost cutting or maybe optimizing the services of a particular OPD or equipment. But somewhere the continuum of care that is started taking a back seat, which I feel is a concern in my understanding. It's open to the forum to throw more light on that. I think these things go hand in hand, parallel. Certainly the use in our hospital of business intelligence is more by the administration than by the doctors, even though the doctors know that it is there. They come once in a while if one of the PG students wants to get a list of the last 500 patients with rheumatoid arthritis so that they can bring them up and get a follow-up and things like that. Although I did demonstrate that yes, this operation, what was a presenting diagnosis, practically the doctors are not using it. But they are continuing to use the remaining HIS.
When we are saying about security and privacy related to technology, I think we have to trust in order to derive value from the system. We have to trust in order to derive value from the system. Unfortunately or fortunately, we are not at this step where we have formalized the standards So whatever is happening, I think we have to trust it. There is a system wherein we can control the security. We have to enhance it. That is what we have to do.
About privacy, there are a lot of concerns. Sometimes I also find they are a little over-concerned about privacy. There's a typical example of a political coup had happened in the country of Trinidad, and the arms in the city had been kept under a lock, which was, the password of the lock was encrypted with AES encryption given by a certain company. The only two people who knew the password were the first one to be killed by the uprising, and the city was unable to crack the code. Even when they called up the company who had given the encrypting algorithm, they were not able to break it out. The city did fall to the revolutionaries. So sometimes the coding standards can actually match. But as you rightly mentioned, it has to be the trust of the people to believe that this cannot be hacked. Otherwise, there will be no lock that can be created which we can say that this will definitely or 100% not breach any kind of privacy whatsoever. So somewhere this privacy and the concern about the data being on the cloud is open or simply hackable.
Put your hands up. Not too many, okay. Let me just share you this experience. In the US, we are implementing inpatient electronic health records on the cloud, fully HIPAA compliant, and there are no issues. Okay, security is an issue that we can keep discussing, but I think it is as safe as anything else.
There is a lot of skepticism of using cloud in India, but I want to reiterate the point which Dr. Denham said, that you can invade, you can conquer and invade an army, but you cannot stop an idea which has arrived.
It's easier to get to a paper or get to the cloud.
Thank you, Dr. Anil Kuthiala. We have one last talk which is actually supposed to be in the other hall. The session actually has to give a talk here, so there was an overlap, so it's been moved here. And this is by Mr. S.N. Raghu Kumar, who is a system analyst and in charge of network in Aiims. And he's going to talk on design and implementation of Wi-Fi based access network for healthcare professionals at Aiims.
So that I have taken some time. In my talk, I am going to explain about the Wi-Fi implementation we have done for our hostel students, staying at 20 locations in different parts of Aiims. Within the campus or outside the campus, we have done some Wi-Fi implementation for them to access the journals what we have subscribed at the Biennial library we have at the central library. We have around 500 journals, online journals subscribed to them. They have free access to that in our network. They will be sitting anywhere in the hostel premises and they will be browsing there. Then we are here to show them how we implemented the Wi-Fi.
Design and implementation of Wi-Fi based access network for healthcare professionals in Aiims, New York. This is little about Aiims. The All India Institute of Medical Science is a premier medical education institute working in the area of patient care, medical education and research. There are around 10,000 staff and 4,000 students and 1,500 students staying in the 18 hostels in and around Aiims campus.
These 1,500 students stay in different hostels. Some hostels are within the campus, some hostels are 4-5 kilometers away from the campus. We have created direct link wireless link to provide them the Wi-Fi. Next.
This is Wi-Fi, hostel-wise Wi-Fi user. There are 18 hostels, and hostel, the list is in hostel 1, the total number of users are 48, 245, 56, 57, and the number is 400 approximately. 1400. The course-wise Wi-Fi user: BSc, DM, Junior Resident, MCH, MSc, MBBS, MD, MS, PhD, and SR, Senior Resident. The number BSc students are 111, DM 8, JR 303, MCH 10, MSc 119, MBBS 340, MD 23, and MS 5, PhD 207, and SR 257. This is Wi-Fi Implementation at Aiims. So the diagram is the slide. The main radio which connect different hostels, and the main center is the computer facility where our the main switch, a DSCP server, and other devices are installed.
This is a hardware representation.
Because I have given a presentation upstairs.
We have connected our main data center, which is in the center of the hospital, to different locations through what we call P2P links. P2P links are again wireless links. We show the distribute the signals through wireless, and it is cached at every hostel differently, and it is distributed through access points. Access points kept at the different hostels. So now we have different point-to-point networks pointing to hostels, and within hostels they are distributed through APs.
This is another how this all hostels are connected. This is the showing the main and further link to the other hostels. Wi-Fi access mechanism at Aiims. Approximate 1400 students accessing Wi-Fi network by 24/7 into 360 basis. Providing connectivity through the zone for mobile, laptop, PDAs throughout secured access. The MAC address-based authentication, web-based encryption 64, and IP address assigned through the DSCP server.
The access mechanism is like that everybody who owns a laptop or PDA or any sort of portable device or even a computer, they are given with Wi-Fi access. They have a dongle or something to be connected. They have a MAC address which is pre-recorded in the main computer facility. The MAC is matched and the access is given to prevent unauthorized access for the user. Only access is given to the MAC users which are binded with the network.
This is one hostel which is showing the connectivity. The bandwidth available at Aiims: 45 Mbps from Marnet and 100 Mbps from NCMI.
NCMI is the new node which is provided by NIC to all medical colleges in India. Through NCMI we can connect all the medical colleges in India. For example, we have done recently we have done a surgery at our 8th floor in our surgery block, which is seen by the students in Coimbatore. all the 4 hours they will continuously see. Like this we can connect to any part of our country and do online video transmission, online teaching, online discussion, anything is possible, which is through National Knowledge Network of India, which is giving 2 Gbps connectivity, which is a great pipeline. We were having around a year back only 2 Mbps, 3 Mbps. Now we are given a Gbps connection, which is very useful to medical colleges in India to connect and discuss and show our live surgeries to other part of the medical colleges.
Next is bandwidth distribution. We are using Groves APs, station 1200 MES and AC 100 D2 HP APs were deployed, enabling campus-wide Wi-Fi at Aims. Wi-Fi mesh nodes were placed strategic location inside the campus and support 802.11g, which is working on 45 Mbps, 54 Mbps capacity.
The access points is provided by Brovis are capable of transmitting the signals up to 100 meters, so that all the hostels, we have around 48 access points placed in strategic location, so that they are focused onto the hostel rooms and the signals can be catched by the students for browsing.
Hostel-wise access point placed, deployed. So this is the list. In hostel 1, 2 APs, hostel 2, 1, hostel 3, 2, and so on. Use of Wi-Fi at Aims, primarily used for academic research and online journal access. Next point is, there are around 500 online journals subscribed by BB Library Aims, which are being accessed by the student on Wi-Fi network.
Basically, this is called an academic network for accessing information. Whatsoever they want, they can do it from internet, but mostly used by the students for our online journal. Online journal subscribed by BBDL are here.
You'll have to finish in 5 minutes.
Yeah.
Okay. Online journals subscribed by BBL, the journals start with is so list of online journals which start with the academic of emergency medicine.
I think we can skip the list.
Okay.
There are around 500 journals subscribed by BBDL are available for students to access. That is the main point.
Other is Wi-Fi networks for general internet used for various applications like email, download software, ebooks, etc.
And we are planning to give our e-hospital access also to our residents. So residents staying in the hostel can see each ICU, even every monitor in the ICU can be seen at his hostel room directly.
Challenging issues facing Wi-Fi network. There are approximately 1400 students accessing Wi-Fi network. Some area horizon created within the hostel or having signal strength problem. And next is roaming facility and AP limit 25 to 35 per AP.
Roaming facility is that one staying in one hostel cannot go to another hostel and browse. That we are enabling in the second version of the implementation, that any hostel they can go anywhere and start roaming facility and start using it.
Solution to challenges: increase number of APs, BG to BGN technology, fiber connectivity of 10G to individual hostel and distribution through APs within the hostel, and provision of controller and NMS.
We are redesigning our whole Wi-Fi network to be not only Wi-Fi based, it will be hybrid based. That access will be given up to hostels through 10G fiber optic, and then within the hostels it will be distributed through APs. So APs will be distributing within the hostel, and the fiber backbone will carry the signal. Right now the signals are carried by Wi-Fi, which is having a limitation of 80 Gbps only. Since our backbone is 2 Gbps, we want to give the full strength to students, so that we are thinking of taking fiber backbone up to the hostel premises. From there we will be distributing within access point. The problem is that the hostels are there in around 3, 4, 5 kilometers away also, which is cutting through MCD areas and other areas. Taking permissions for connecting is a problem. So we are working on methods of connecting them through fiber Wi-Fi first, and then giving through fiber.
I think we'll have to close now. Just a minute, most of them.
Provision of controller and their function, simple centralized function. So it's a deployment from the network is to the core, seamless entry roaming, flexible policy enforcement, and protect network from unauthorized users based on the site. And this is the centralized monitoring system, from where we can monitor each and every
access points, whether it is working or not working. All those shown in green are working and fine. All those shown in yellow and red are having some problems. With this thank you very much.
Thank you. Any questions on this?
How much is utilization? Yeah, utilization is full. We need more bandwidth. For example, we have got recently NCMI bandwidth of 2 Gbps, which is used to 80% of the limit. Yeah.
Thank you so much. Can I have Dr. Sanjay Bedi to please present the mementos? I'll have to ask the organizers. So maybe just a shake of hands and we'll give you the mementos. Sorry for that. And the same thing with Mr. Raghu Kumar. Yeah, thank you. Sorry, there seems to be a problem with the mementos. Thank you, and now for lunch.
Off-the-shelf Wi-Fi component which takes a lot of power, so you have to actually plug it in. You don't have to plug it in, you can run that radio on 2 pencil cell batteries. Now, it can bone conveniently at the waist or the ankle. So here's a typical fall event. In the application, when a person falls, something like this is visible, that a certain event ID has been received from this node at this timestamp, and this is the description. And you can have all the other software piggybacking this event to notify the concerned authorities. A typical deployment scenario, as we see now, is a geriatric care unit where we, let's say, monitor the elderly, and the objective is to auto-notify things based on the postural events. For instance, change of posture from standing to walking to sleeping to running, let's say, or to detect things like falls. Now, when we look at a deployment scenario like this, it's very much possible that one or more nodes may not be in the vicinity of other nodes. In that case, it may not be able to notify because it essentially relies on relaying the node using other nodes. So, when we look at such a scenario, we have to have certain nodes called relay nodes that act as intermediate nodes for the other nodes which are responsible for monitoring the events. And this also ensures connectivity of the network as a whole. Of course, we have integration with other systems as it's very usual with such applications. So this is our typical example deployment that we have created, let's say with Aiims as a possible deployment scenario. So what you see in the background is a Google Map satellite view of Aiims itself. What you see as circles are nothing but the sensor nodes. So you have a set of 5 nodes where the 5th node is talking to the first node through node 4, 5th, 3rd and 2nd. And node 1 is closest to the gateway. The sensor node is worn at the waist in the manner shown, and you have a set of events which keep on coming from the network and the log keeps getting generated.
So you have 5 more minutes.
Yes, I'm almost done. So we would like to conclude by saying that we have developed a system, and one of the purpose of attending this conference is we want to identify test beds. So we would request the panel also and people from the audience, if you want to try the system, we welcome to your request, and we would love to come down and see the system at your place, and we would like to do a pilot exercise at your place. The system notifies fall, which is a very common cause reportedly, and the reason why we got the funding also, this project is of course funded by DST, titled Development of Wireless Sensor Network-Based Gate Assessment System for Fall Prediction in Elderly Patients. And we also believe that systematic recording of all gate-related events can also help doctors in future to predict certain anomalies. For instance, let's say development of arthritis or any such other orthopedic problems. So this is the contact ID. We work with Professor Subrat Kar. If you're unable to see the email ID, I think it's visible there, it's not very visible here. So this is the phone number and the email ID. We would love to hear from you. Thank you so much. Yes, we also have a video. If you like to see the video, we'll show you the video. So this is the video we recorded. Prototype, about months back.
The smartphone, as soon as it falls, the smartphone transmits an event, that's a ball event, and it reaches the gateway, and from there it takes the other application. This is the gateway application. We first connect to the gateway. After that, we open event manager and location manager. And this is the previous game. So now it's here. So I attach to the network, and then when it falls, the event will be displayed along with the location. That's it. You can see here, and it attached on the network. When he fell down, we saw a set of 2 events which were transmitted. And corresponding to that, the location of the node was also transmitted from the sensor.
This is a very early version of the prototype recorded about 8 to 10 months ago. So now we have a much more refined system. Thank you.
Thank you, Sunat. And the forum is open to questions.
How so the node is differentiating, between different postures? How will the node differentiate between a fall versus a person sleeping? Because it's same posture.
Not exactly. It's not about posture identification. Of course, is a matter of the orientation of the accelerometer.
Right.
So standing and sleeping is changed orientation of the accelerometer with respect to gravity. And fall, when a person falls, there is a temporary free fall condition created. So when a person falls, there is a temporary sense of weightlessness which the person doesn't actually experience, but the device can sense that. So it senses that free fall condition to detect a fall.
Okay, so it's not really the posture, it's actually
No,
the
it's not.
process
Right,
of
it's
the
the
fall
process.
which is. Okay, my second question was, the way you were talking was about the interconnected nodes. So it has a lot of application in terms of a group home where a lot of elderly are staying. But still in India that concept hasn't come in. I mean, I work on the elderly and disabled population, not in India so far but in the US. But the concept of group homes hasn't gotten up that much, and still we have the majority of elderly who live in home, at home, but they might be living alone when they don't have a caretaker, a son, a daughter, or any other person who can take care of them. So in that case, does these nodes have any applications if there is a single elderly staying in a home?
Of course, it's applicable because the nodes, the sensor network is scalable. You can have just one node or you can have 1,000 nodes. It doesn't matter. Because essentially these are all self-organizing mesh networks. So if there is a single node in a room with the gateway, that single node will talk to the gateway. If there are n nodes, let's say 10 other nodes, they organize amongst themselves to find the shortest possible route to the gateway. So due to that self-organizing capability, even one node is not a problem.
Okay, so if it's implemented at home, then the wireless network has to be in place at home. Is that true?
It's not required. That's why it doesn't use the legacy network. The node has an onboard radio transmitter. It works in the license-free ISM band, that's 2.4 gigahertz on which Wi-Fi works. But it's a low bandwidth separate network created by the sensor nodes themselves. So it's not taking the Wi-Fi or the other networks into consideration. Even if none of them are there, even if there is just a LAN connection to the gateway system, then that can be used for sending out notifications, your emails and stuff like that. And the other nodes are wireless nodes, and they talk to the gateway using the wireless medium without taking help of any of the other legacy networks, Wi-Fi or IMAX or cellular.
So there is some such equipment which needs to be placed at the home of the individual. Is that true?
That is only for the gateway. Only the gateway needs to be placed, nothing else.
Okay.
Just one, it's like a terminal device like a phone. Okay. Only that one system needs to be connected. And in fact, if there are too many homes in the vicinity, that gateway need not be placed in one particular home. It can be placed at a centralized position, let's say at the administrative unit, and all the homes can just have the sensor nodes. And using the connectivity, the auto-adaptive property of networks, they can all talk to the gateway using other sensor nodes as the intermediate nodes.
So it can work like a community.
I would request that any further questions can please be taken offline.
Sure.
In the forum, is there any other question? Would you like to ask me?
Instead of using the sensor network, one approach I would think about is use a cell phone network and send an SMS notification to a central server. And the advantage there is, let's say, in a single home situation like the lady talked about, you could even have a service provider who reacts to that and comes home and checks that everything is okay. So. I'm not. The utility of sensor network is. Is it really do a cost-benefit trade-off there, where instead of using cell phone network,
we actually started the discussion with that as a premise that if we have 100 such people who want to be monitored, and each person is sending an SMS, then you have actually 100 into the number of 1 into the number of people SMSs being sent. So here what you can do is you can aggregate all that information into a single SMS or a single email, because all those sensor nodes can talk to a single gateway, and there's a significant cost advantage, which is actually number of times the number of people in the room.
So Bruce, I think what the point he's trying to make is the ubiquity of the networks. These kind of networks have to be created, and vis-a-vis using an already existing infrastructure, in which it's quite possible not to send an SMS for each event, but maintain the same intelligence through a relay node, which may be somewhere coalescing with the mobile networks. So that's the point I suppose you're trying to make.
It's very rare. I mean, somebody calling is something that you have to react to very immediately. It's very rare that you have 100 people calling at the same time.
That's true. But the network still needs to be created. The principle is that when a person calls, if it's a close-knit home, and there are other people who are not necessarily falling. They might be in some other state, but they all the same, all of them have a sensor node each. So that fall event is sent through these other sensor nodes, which are at the moment not doing anything, to the gateway, and the gateway can immediately react in multiple ways.
We have bundling of traffic.
Right.
Yeah, thank you, Sanat and Akshit, for a great presentation. We have our next presentation from Shilpa Kayastha. The speakers, Shilpa and Neha Sija, will talk about Telehealth Center for Rural India, a bottom-to-top approach. I would now request them to start their presentation, please.
A very good afternoon to all of you. Before we start our presentation, I would, with due respect to all the senior delegates over here, we think that our presentation is quite rudimentary as compared to all the presentations and enriching experience we had in these 3 days. At student level, I am Dr. Shilpa Kayastha and she is Dr. Neha Sija from Institute of Health Management and Research, Jaipur. And the topic goes as Telehealth Center for Rural India, a bottom-to-top approach for improving healthcare facilities in rural remote areas. The overview of the presentation is, we'll go by introduction, healthcare paradox, insight to telemedicine, SWOT analysis, barriers to telemedicine, proposed model, and the probable solutions. Rural development, according to us, is the prerequisite for national development, because 68.84% of India's population still resides in the rural areas, and most of the secondary and tertiary services are present in cities and towns. So definitely we can see the low penetration of healthcare services, and there is lack of investment in healthcare. According to us, the major problem in rural areas is the retention of doctors. The medical and diagnostic facilities are very less present in the rural areas, but the basic problem of retention of doctors we consider as professional isolation they feel in the rural areas is a major concern. According to Mr. Bill Clinton, he says that it is very devastating for a population when half of the world is on the cutting edge of technology, and similarly the opposite half of the world is just at the bare edge of survival. Yes, I'm talking about the rural health divide. It's both in terms of technology as well as geographical. This is an unfortunate paradox, the healthcare paradox. We can see a top-down integration of the three-tier of health system. The demand in India services is always after the illness has intervened. It's never before the illness intervenes in a place. So we can see that the pressure on financial resources is so high at the upper side of the pyramid that it creates a ever-increasing vacuum at the lower side of the pyramid, and it increases the rural healthcare services needs. It continues increasing. As we see healthcare services demand in India, primary, secondary and tertiary care. In primary care, the basic healthcare facilities for common and minor ailments where prevention is most effective. In secondary care, healthcare facilities that require constant medical attention, including short period of hospitalization. And in tertiary care, conditions requiring care from specialized clinicians and facilities. Whereas we see the reverse in the healthcare services supply in India, in which all the services are present in the urban and semi-urban areas. It's like maximum concentration of corporate healthcare in the urban areas and highly fragmented and unorganized sector focused mainly on the secondary care in the semi-urban areas. Whereas rural areas, even primary and secondary care is at times elusive. We did a review of literature in this, and the three main reasons we could find for this reversal was basically we just provide service. We are making more infrastructure, but the provision of services is still lacking. Secondly, there is less deployment of staff. And thirdly, there is a top-down approach in which all the three care levels are not integrated with each other, and there is lack of community participation. For this healthcare paradox, we could find the solution of, we all aware of telemedicine. This is a definition of telemedicine. The types of telemedicine, store and forward and two-way interactive television. Technologies do come and go, but the implementation is a major requirement. So if we want to introduce this telemedicine center at the lower level, first we want to ground it at the rural areas. So we want a store and forward technology when it comes, like in the rural area, it gains its ground, and then we move to two-way interactive television, because implementation is a must. The evolution of telemedicine went from point to point, then point to multi-point, and finally multi-point to multi-point. Through the thorough review of literature, and we read all the existing models in India, especially the Indian Space Research Organization and the Apollo hospitals, we could come to this SWOT analysis. The strengths being improved accessibility, continuous medical education, weakness was limited awareness of telehealth and its benefits, sustainability of the model. The opportunities were continued technical development and innovations, expanding internet literacy and usage, and threats being concern associated with standardization, medico-legal aspects. Through this SWOT analysis, the common barriers which we found in all the models were, to this model we want to implement in the rural India, were socio-cultural barrier, legal issues, economic issues, and technological issues. The basic factor was socio-cultural barrier. Even if technology can't penetrate, unless and until the social prejudices or their hostility of the rural people about this new technology is not removed. They are apprehensive about the technology, and they don't find that virtual concentration a good method of diagnosis. In legal issues, yes, there is lack of standardization still in India. In economic issues, there is lack of funding. There is still people are not ready to invest their money on this. Then in technological, of course, there is no bandwidth penetration in rural India. As base, keeping Indian Space Research Organization as base model, this is the basic structure which is already existing. In this, when we did the review of literature and the things we are working in different hospitals, we have combined that in 3 things, and we have modified this model a bit. That there are 2 things: consultation center being the district hospital in Indian Space Research Organization, and a specialty center. But we want district hospital to be replaced by primary health center, because primary health center is an echelon between, it's a first contact between the rural people and the doctors. So primary health center, as the number is so huge, so we want primary health center to be the consultation center. Secondly, to involve community there, we would prefer the person who is behind the video conferencing, the technician, we could train him. He should be the person of the community, for the people, by the people, and of the people. And this would overcome many of our barriers, especially the language barriers. He would be sensitive to the needs of the people in rural areas, and people would be comfortable in approaching him. And even if some health problem is going on in the community, then definitely he can address that to the healthcare services. Finally, if we still find that the telemedicine center in rural India is still not cost effective, the diagnostic services or the lab services that can be outsourced. So we want to concentrate on the left side of the model, so that if we provide services at the primary area, that would solve all the problem, and there will be no overburden at the level of CH or district hospitals. This would be the model which is already existing, level 1, level 2 and level 3 of primary health care, and there is a 3 hierarchy or the 3-tier level of health system. The phase would be data preparation and transfer phase. Patient's medical record and related measures are transferred from consultancy center to specialty center. Teleconsultation date is fixed. Then comes the consultation phase. Depending on the availability of requested doctor, the appointment is either accepted, rejected or kept pending. The appointment details are sent to the consultation center. And finally, the post-consultation phase. After the consultation, the doctor gives his opinion on the case and instructions through a post-consultation page, and patient information is stored. We could address only few problems through our model. So further we're looking on the models we studied, and the points we could address were: the way forward we can say a well-integrated public-private partnership, expand reimbursement, user-free charges for self-sustainable model. Many of the government sectors, they are using this user-free charges, and this will promote equity. And obviously, the cost equipment investment is so much high for the equipment, so by user-free, a little amount if it goes, that will help in the sustainability of the model. And in social franchising was a concept which was followed by an India-based NGO, World Health Partners, in which they find people in the community, those who can act as entrepreneurs, and they help in opening up a medical unit. We can promote community participation, then establishing standards to minimize variation. Still, standardization is lacking in India, but now we are trying to adopt European standards, and HIPAA is there, then Health 7 is there, and DICOM standards has been adopted. So there is a move on in the telemedicine project, and finally health services outsourcing. So it's on us that we are socially responsible. Either we maintain this inequality or we gear ahead to remove this equity, which says that health for all is no more just a dream, it becomes a fact of life. So telemedicine is one small step for IT, a giant leap for healthcare. Thank you, sir.
Thank you, Shilpa. Neha. The forum is open for questions.
I agree. This bottom-up approach is very important because the problem we are facing is if the moment we go top-down, there is a problem of integration. And big problem we are facing is that only the topmost institutes, they are linked to telemedicine. The workable model is that some local, from village to a local district, that should be linked. The instead of only Aiims or only Sanjay Gandhi PGI, we need some kind of models where patients from very local areas, they can be linked.
Yes, sir.
But once that is, because that will create a business model.
So it's already working in Tamil Nadu in Thane district. They've started regarding PHC as a consultation center. So we want that this model should be replicated. So like rural India should be addressed first, and then we can go ahead for the national development.
Yes.
Thank you, sir.
Is there any question?
What kind of equipment that is used in the primary healthcare center for the teleconsultations? What is the proposal? What is the model on that?
Thank you for the question, sir. So actually, if we think that whenever telemedicine is being talked about, it's all that cost effectiveness is still not there. So if we are just thinking of a consultation kind of thing, because we want to link all the hierarchy levels, the 3 tier of hierarchy should be linked. We are not just concentrating on PHC. Even if we just provide a consultation there, we want that if diagnosis is not available, because there is only one regional medical practitioner, so he should refer at CHC and take a proper appointment so that the patient cost is saved in going there, even if the doctor is not present at CHC. So basic computer, PC, sir, and sir, the software hardware requirement. And so now if like the Indian Space Research Organization, through their program of HealthSat, they're providing the technology, the satellite, free of services to the government. So we can use that.
So it will be a video conferencing things only.
Yes, sir.
But there might be some medical equipment which can be used for capturing the data.
Yes,
and transferring the data.
Yes, sir. So that's why we're saying that to make it cost effective, we can first ground at the level of store and forward technology only, and then we move to real-time consultation. Because to be cost effective also and to see this set sustainability of the model, we'll start with store and forward. And the other thing that lab and diagnostic you're talking about, we're talking about public-private partnership or outsourcing kind of thing to be introduced.
Okay.
Thank you.
There's one more question.
Thank you very much for that presentation. You did talk about the medical legal issues. So if you could just shed some light on that. And you mentioned World Health Partners. I know that they're doing extensively in Western UP.
Yes, sir.
And how do they address medical legal issues? Because as telemedicine is expected to grow, it may not be an issue now, but in the years to come, it will become an issue.
Thank you so much for the question, sir. So medical legal issues are definitely for the rural people, it's all that it's a virtual consultation, and these people think that when their personal information is linked in that electronic patient records, so they're not comfortable sharing that. And that's why for that, we think that if we involve a person of community participation, the thing we talked about, that we want that person to be involved because it gains faith in the rural people. And sir, in that NGO, India-based NGO, World Health Partners, so basically their step is same as community participation because they're involving a person who is rich enough so that he can sponsor. He becomes like an entrepreneur there, and he can sponsor because it's costly. Obviously for the rural people it's costly. So he's involving the community person to build in faith in the rural people, and they make a medical unit out of that. So they're working, making people of the community as entrepreneurs.
Thank you, Shilpa and
Thank you,
Neha.
sir. Thank you, sir.
Just to add a little point to the presentation, telemedicine has been a promising child of the medical informatics for a long while now. It's been 10 years since I established a telemedicine center. It hasn't really taken off in the way everybody expected it to take off because of a lot of barriers. Among some, she mentioned, but there's another barrier, which is the genuine concern of the physician who is offering, apart from the medical legal aspect. The genuine concern of the physician that if I cannot palpate a liver, I cannot make an opinion about it. It is the actual touch, it is the actual consultation with the patient which is missing, which does impact the comfort level of the physicians themselves. And of course about ISRO, the first time I had taken the bandwidth, the cost was 40,000 rupees an hour. And that was about 10 years ago. Now of course it has come down, but now there are enough internet-based technologies which can transmit the images in live videos and sound also. And ISRO VSAT system is not really required anymore, except for perhaps very far-flung areas where either mobile or internet penetration is completely missing. So somewhere based on the back of that network, maybe telemedicine will be utilized better. And perhaps for things which can be an adjunct for medical practice and not necessarily just a clinical consultation, a diagnosis and a prescription. Maybe a lot of adjuncts like teleradiology, telepathology, a lot of other things can be used using the backbone of telemedicine.
As you know, I'm from Sri Lanka, and I was working with the World Health Organization about 8 years ago in the development of a telemedicine module for Sri Lankan hospitals and rural centers. That system failed. And the reason mainly why it failed is because the central group of consultants were unhappy with the situation. They'd had no experience of dealing with patients that they couldn't see and they couldn't examine. And apart from being nervous, as was mentioned, about the medico-legal aspects of giving advice without full amount of information, there were also, of course, economic factors that you don't know how much to charge for a consultation where you're just giving a very small amount of information. So I think that telemedicine, as was mentioned, can work in very precise, specific areas, like analyzing an ECG, like describing a chest X-ray, or something like this, or perhaps even advising on the new antibiotics that they might not be familiar with in the field. But to see it as an alternative to well-trained people out there in the field who know how to examine, who know how to deal with the patients, I don't think it's an alternative to that.
Thank you, sir. We'll move on to the next presentation of a personal eternal health passbook from Dr. Mowgli.
Chairpersons, good afternoon, ladies and gentlemen. You're able to hear me? Yeah. What I'm going to talk about, personal electronic health passbook, like your bank passbook. This is the passbook for every individual. Now we are all trying to integrate by electronic health records to make swift, safe, quality and cost-contained records so that all over the world, patients go anywhere in the world and get the treatment so that all the information available in that. But still we feel there is, though let me not talk about electronic health records here, I would like to mention there is still, in spite of if you successful in that 100%, still will not be 100% succeeding. There will be something left over. On that point I am trying to focus, and I want you from your feedback to see we can improve further. And when we are developing electronic health record system to ensure that 100% providing health care, safe care, swift care, quality care and cost-contained care, think about this also, if there is a possibility incorporating into that system so that later we will not have another deficiency. So, evolution of medical record, as we know, it started on the stone, on the slip, on the hoods and all. Later it became a patient chit. Small paper given to patient. Later we have doctor specialists like ENT, ophthalmology. They said the chit won't help, they need. Then they started a card. Then it became integrated. Each department has separate records in there. Finally they brought one integrated saying comprehensive record, unit record. The unit record is basically one patient, one record, one number. So entire thing about the hospital, particular hospital, should come in one, not to have 10 records. If the ear man has his record, ophthalmology other man, dental man other record, and gastroenterologist other, it doesn't work out within the hospital. So coming to what is the personal eternal passbook, I think like your passport, when each individual should carry with him, it should contain from birth to till death, and it has a more than allopathic information. You have a non-allopathic information available, which is otherwise you don't have. So P is perhaps the key individual. He is the owner. He owns it, and right of access also individually owns. So basically what happens, what EHR has cannot have, what PHEP can have. Basically personnel suffering from minor ailment don't go to hospitals. And they don't visit hospitals and apply self-medication, self-care, self-treatments, and extensive information of internet, website. He himself can take some medicines today. If you do have this problem, have your own medicine, goes pharmacy, buys and takes. So non-allopathic treatments are taken, as you know, Unani, acupuncture, homeopathy, Ayurvedic, yoga, health, and so on and so on. So all this also undergoes in the lifetime. So types of health, they can be maintained by paper-based record, or PC-based, or web-based, or hybrid of them, then connecting through USB port or the user computers. So we can have two figures. One is related to organs. If a particularly patient suffering with a liver disease or a lung problem, and the excuse is that, then you can mark on the date that what area is suffering and what date, so that you can continue. If he has a problem related to organs, then close related to second one, and see there you mark it and the date so that it continue. It's not one, you can have a number of pages of that. So other doctors who is treating will have an information. So what should be the PHP? Should contain. It should contain, of course, patient identification is a must. Health summary, child development, immunizations and so on, medications, hospitalizations, especially for offspring gynecology for women, and so on. So now I will let you the idea of my coming out with some idea. Now we have to work out as a IT people how we can incorporate and see this, and the individual passbook can go together, integrate that, so that the person who goes, after all we are all living for patient and for all the hard work going for the patient, and he is our master, he is our God. So if that is the objective, then please see that he gets 360-degree care. The patient ID format has three parts. One is personal identification. Second contains the habits, allergies, blood grouping and so on. Third is habits, is food habits, or the environment, or is the place the games, or the alcoholic, or whatever. Those habits also comes in this. Then I have given the format that might help if they are, or they can modify and see this type of format are needed in each hospital. When they get the treatment, you cannot fill all the information, but there should be standardized format which go minimum information in this USB. The patient care summary, especially this form, is very important because wherever any problem, a diagnosis, the self-care, what he has cared, he notes down himself. If he is admitted or he has gone to outpatient information. If he has gone to emergency, there what has done, whether he is admitted or not, if he is admitted, hospitalization, what date of admission, date of this, and so on, so what the diagnosis and the outcome of that. Coming to the child development, of course, between 5 and 14 years, we call after 14 years. In India, still 12 years, but at the WHO's world, all things 14 is the child. To kill that bird, you should have a child record. Coming to immunization, of course, these are basically children, but sometimes even adults have some leftover boost. That also can be entered here. The self-care for medication. This is basically self-care, non-allopathic. So, there whatever types of different types of medicines, this record is completed. This is what he keeps maintaining this. Whereas allopathic, those things, medications ordered by physicians in the hospital, which are the outpatient emergency, wherever, all the information goes to come in this route, interval, quantity, the days of refills, also and so. The pharmacy, various will taking all. The investigation. Now, whatever the investigation undergone, those summaries information is available in this format. Hospitalization record, naturally when he is admitted, what date he discharged, what hospital, what purpose he was admitted, what was the outcome of the hospitalization. So obstetric gynecology, of course, for women, the need for pregnancies, gynecological problem, obstetrical problem, that is a must. Therapy. You can have physiotherapy, occupational therapy, biometric, whatever, you have different types of radiotherapy and so on. All therapies go into this format. Now, people born, now if you start today or you start going to 2013 or 14, but till they have the first record, that whatever information you think important should go and collect from the institution, and is especially for chronic cases is a must. You collect and also take permission from the hospital, this information will be released to others. Others means the physician, authorized physicians, not anyone. So they should have permission from them because their information cannot be released anywhere. But you being patient, but you have certain rights, you have certain obligations, certain privileges, but not all the rights you have. The hospital has certain, take permission from them, authorization to release your information to other hospitals. Then you have carry a pen drive or the system where you can get it copied. Because this is always going under questions, how you copy so much information, that's where I have come. The point is summarize, bring it to uniformity little, and what is minimum required.
Dr. Mogli, you have 5 more minutes for the
Sure. Give me 1 minute. The conclusion has come. EHR at health institution level, at PHP at personal level. As I said, EHR wonderful, but still it has 1.1% deficiency or person you have to calculate. For providing continuity of care to patient at all time, at right place, at right doctor, at right cost. The PHP allows the practitioners from different settings and discipline to share information. Allow the patient to carry this information wherever he goes. He may say any part of the world. It could be in your side, it could be in Russia, it can be New Zealand, Australia or Netherlands. Coming to the point is unity now. He goes to a doctor, a normal condition, or you may have a physician somewhere, or you may have a non-allopathic therapy. There are so many now. Every day something new thing coming up with non-allopathic side. Please look after those self-medications and type of diseases he has. Thank you so much. This I am sure this paper is not going to give you all the answers. It has something, but it tells you we do all so much. There is something more we have to do. Please keep that point as IT experts to developing EHR. See this also, make a uniform standard so that it becomes easy. At that time, don't search for later. Now a question came before telemedicine. Still we have not achieved anything in that. Hardly a 0.1 also, but medical legal issue comes. So it's good. You start thinking now so that the problem won't come. No policeman will come near to us. So let us see. We never allow a police person to have in the patient care side. If we have taken care of, if we do well, nobody else will go. That's why the whole idea is giving you some information what to be done. Thank you very much. If you have any questions.
And the forum is open for questions. Due to paucity of time, we'll take only 2 questions, please.
Lighten us that how PEHP is different from PHR. We have a concept of personal health records, like on EHR. If an individual also annotates his own personal history of allergies, immunization, and they also carry lifelong. And there are other formats also, like Dr. Jackley brought out yesterday, that in a pen drive, if a patient asks, he can be given in a his health records on request. So basically, like if you propose PEHP, then what standards, codes, formats will it take? Those are the critical issues. How will they be accessible to other doctors? What is the standardization and regulatory norms, formats will they be following?
Yeah, that's exactly I wanted. What I have done, I have given you some formats developed. Then I have given you on different formats. Now we want to look at an IT, all we have to expert bring together, and these formats will help us to summarize so that summary information go to ESP easily. Otherwise, so much information available in the hospital, all that converting into this way is going to be impossible. It's impossible. Once again, we say, ask somebody, write about 5 minutes, won't help. So that's why I am talking about why I am trying to influence or invite. So the idea is to now this problem, these are the format I have given, now with the discussion formats. Whether they are okay or they are incomplete, or we can modify, add or subtract and make it and bring the standards on them. So that any hospital.
Hi, hello. What I'm going to talk about is how do you use health IT or IT actually to make healthcare more accessible, because for the last 3 days we've been hearing about presentations which talked about use of IT in various contexts, but the challenge still remains is in India, healthcare as it is right now is prohibitively high. Most people can't afford to pay for their healthcare. Some standard numbers that you will see in all the in development sector when people talk about healthcare, that most of it is out of pocket. And a WHO number that's commonly used is a percentage of people who spend more than 1/10 of their income on healthcare, and that's 14% in rural India. The first point I want to make is that the way we use IT in healthcare won't fundamentally reduce the cost of healthcare. We have to be more innovative about looking at the entire system and thus bring the cost down. I'll give you some example of the kind of interventions that we need to do. Obviously cases of diarrhea, waterborne diseases are pretty high. When we look at it from an IT perspective, we talk of VHR where we capture it. But to really fix the problem, you have to go one step beyond. You have to look at what interventions, what preventive interventions you can do to reduce the incidence and hence cost of it. Similarly, a lot of secondary hospitalization cases that happen. Can you do something? Can catching them early at a primary care stage reduce the complication and hence the cost? And that's the kind of thing where IT can play a fundamentally important role. There are various interventions that are there by government, but then most of them suffer from lack of effective evaluation of them. So I'll tell you why. These are the various components in healthcare system, and what happens right now is there are various IT systems which take care of some specific workflows. So you'll have the hospitals, insurance companies, TPAs under the insurance management system. You'll have hospitals and maybe labs and pharmacies in hospital information system. You'll have government doing its own vaccination, the ANC doing its own record, clinics doing its own EHR, EMR. Now, what that makes it hard for me as a system, or the IT as a system, to see whether, say, the fact that if I started using chlorine in drinking water, did that reduce incidence of waterborne diseases? Did the use of ORS reduce the complications due to diarrhea? I can't do that because these are all components in different systems right now. And what the first point I want to make is that it's not that hard to look at health system in its entirety. Here is one approach that we have taken, or an organization or company that we started last has taken, is you play a service integrator role where you bring in the hospitals, suppliers, consumers, which are the beneficiaries, the aggregators, all into the system. And when you link it all together, you have all aspects of healthcare of a single person. I'll just go back to what kind of data you would have about a single person in such a system. You'll have obviously the demographic information, which is people, household structures, where they stay. You'll have, let's say you have some kind of insurance scheme or health financing schemes. You'll have information about who's enrolled in what. You'll have the OPD information, the outpatient history of that person. You'll have, you obviously have the hospitalization history, and then linked to that could be anything that insurance company might maintain. If you're doing preventive awareness activities in the community on various health issues, that would come in as a part of the system. And if you have it all at a single place, you want to learn from it. So you should be able to generate reports, create surveys, and make analysis from the system. I'll briefly talk about one such system we had, or previous, the company that we started had built, Swasth India, where the idea was to make healthcare more, accessible to people by playing the service integrator role. The system was followed the design I had previously described, was built on open source platforms, LAMPs, it used LAMP and it's hosted on Amazon. And maybe probably one of the very few computer scientists here without a non-formal medical background. At various points in time, it was used for insurance claim management. And this is where the portability of the system comes in. We used it we had a health financing scheme that we had launched, where at its peak, we had about 10,000 people covered. And one software system, different view of it, was used for the claims and hospitalization management of people. We used it in 7 clinics across 3 different organizations in Mumbai, Delhi, and Tamil Nadu, and Maharashtra. We looked at trying to put together existing systems, but we honestly didn't find any good systems. Plus, the standards or lack of coherence or adherence to standard made it harder for us. These are primarily system components I had talked about. Some quick snapshots where some very quick snapshots of some parts of this system. So a patient comes in, this is a usage in clinic. Person comes in, everybody has a policy, has a card which specifies a card number. You can look up the family by that card. If the person is there on a visit, you can enter the visit details, subjective, objective, physical exam assessment, and then entire billing details. Same system, same policy, same family. You could look up the entire IPD history of the person. What are the pre-authorizations that might have happened? Hospitalization claims. And back-end claims. So if you had a health financing product, you would expose this view to the insurance company or the TPA. If you're running OPD services, you'll expose this view to the one running the OPD service. Similarly, there were views for community health worker. If there's an NGO doing some awareness activity in the community, they'll get one view. Data that gets entered there gets stacked to the same person. So you can look up individual history, but it's all there in the single system.
Mr. Arvind, you have 5 more minutes, including the question session.
In fact, I'm done with most of the talk. So the call that I want to make, the point that I want to make is, let's try and look beyond traditional HIS, EHR perspectives, which are very vertical and siloed, and look at the health system in its entirety, and then only can we make learnings and inferences which can solve the hard-pressing problems of country, of making healthcare affordable and accessible to all. Yeah.
Thank you, Mr. Arvind. The forum is open to questions. Well, if there are no questions, I would like to ask one. It was a very nice presentation. Unfortunately, I got a little lost. Okay. And I'm still not able to comprehend what is the baseline of the presentation. If we are trying to say that all the systems of healthcare should be in one software system?
No, the main point I want to make is the health system itself has to be looked at in the entirety. You can't look at just as organizations in this space. If you really want to really make healthcare more accessible and portable, we can't look at individual vertical silos. That's the first fundamental point I want to make. And to do that, and IT can play a role. If we had individual systems with clear compliance to standards and clear standards, we could link them up. What I'm trying to propose is one system which built it from scratch.
Right. So now we get the point. I have seen the health IT industry move from monolithic systems to the specialized systems, and this movement, in my experience in all the industries, is cyclical. You develop a monolithic system, then you come to realize that it can do everything in a generic way, and then there are specialized areas where it falls short. Then you develop specialized systems, integrate them to it, and then you have a dozen specialized systems which don't talk to each other, and then you tend to fall back upon the monolithic system again. This is a cyclical pattern till the systems mature to a point where everybody, or at least the majority, can have some satisfaction. If there are no further questions, we can end the session now. Thank you, Mr. Owen. This was the last talk in the session of eHealth 2. With this particular session comes to an end. I would like to thank the organizers and all the speakers for their valuable time. Thanks a lot.
Session. Now we'll have the valedictory. I believe both of you have got your mementos. Or you have not got? Have you got your memento? Saurabh? Not me. Not me. So please, memento. Dr. Denham, you got a memento, no? Yes, sir. Memento, please. Yeah? Anil? इनके लिए memento बस सौरभ के लिए. Okay. Please come. Dr. B.S. Bedi, please give a memento to Saurabh. Okay, now we'll be starting the summary of this session yourself. Have you made it, so Saurabh will take time. So I think you announce the summary of this session itself. Yeah, first. Sorry. बोल दिया वहाँ पे? Dr. Sanjay Bedi, Anil, Mr. Meher को बुला लो. Had done because we'll just be compiling the results. And following that will be comments from all of you, and I hope all of us can come.
Sahi on telemedicine, electronic medical records, medical robotics, from the various models, bottom to up, mHealth computing. It is a wide spectrum. And what now is needed, we have networked with each other, we have gained quite a lot from the experiences of each other. Yes, the new medical education methods. Just now, the summary of these is going to be presented. May I invite Mr. Anil, Dr.
I will be giving you firstly the brief summary of how did we go about addressing the various issues, the different representatives. What were the criteria, grading criteria for the presentations. And lastly, after that, in the second session, I will be giving you the specific comments as given by the chairpersons of the different committees for the oral presentations only, not for the poster presentations. So I will start with the first of all the summary of how did we go about it. We accepted 77. Out of these 77 papers which were accepted, keynote addresses were 5, seminars 3, sponsored talks 7, workshops 3, oral presentations were 40 in number, and poster presentations were 19. What were the reasons why we rejected papers? We received 118, as I told you, and we accepted only 77. The reasons were, first of all, some participants, they withdrew their own papers. There was a duplication in the subjects that were given. That was the second reason. The third was the non-payment of registration fees by some of the participants, although they had given their papers to us. Fourthly was the standard of the papers, of some of the papers was not up to the mark, as was our criteria. And fourth was, some of the papers did not fall into the subject of medical informatics, as we had already told that it has to be a paper dealing with this subject. This is the names of the distinguished people who were part of the active review committee who assessed all these papers. You can just have a look and go through the names. I will not personally call them out. This slide tells you about the different categories into which we had divided our oral presentations and our poster presentations. The oral presentations were divided into the e-health 1 and 2, image processing packs, bioinformatics, robotic engineering, HI's data mining, EHR 1 and 2, and health provision. And the poster presentations, we were assessed in 4 different sections, although the papers were of miscellaneous groups in each of them. This slide, which is projected, shows you the number of papers in each different category which were assessed, along with the chairpersons who did the assessment. This is for the poster session. Now, these papers have been assessed, and subsequently the result will be told to you. So, what were the criteria? You should also know about it. That what were the criteria under which we based these papers, they assessed these papers. First was the content of the paper, the quality of research undertaken by the presenter, quality of presentation and his own communication skills, quality of the slides presented in oral presentations, and the quality of understanding upon first looking poster presentations. Satisfaction level achieved during the question and answer session by the chairpersons and by the audience. Now, in the end, I would read to you out the specific comments given by the various chairpersons for the different oral sessions were undertaken during the last 2 days. Chairperson Dr. S.B Bhattacharya and Group Captain Anjali Alam, who were chairpersons for keynote presentations on the 4th of Feb. They have said the keynote speakers discussed very current topics. The first was the latest buzzword in IT industry, cloud computing. Dr. Jackley spoke about the structure of cloud computing in Tebai Medical University. They noted that the structure of cloud computing was simple and clear, emphasized on its future impacts on biomedical research. There is a need to enhance privacy of data, can have wellness cloud, health cloud, and care cloud. The second lecture on the keynote was by Dr. Janampol about EMR keeping in Sri Lanka. It was a very lucid description of complexity in ICD-10 coding overcome in Sri Lanka by using SNOMED and mapping it with ICD-10. Both were excellent. This means both the papers. Both papers were excellent and extremely thought-provoking talks. The second session on medical education, that was chaired by Dr. Sanjay Bedi and Dr. Manoj Kumar Singh. The comments for this are: the speaker gave an introduction of virtual patient encounters using iHuman platform. Various aspects of patient encounters were simulated. This can help in training medical students in the light of shortage of teachers and patients of rare diseases especially. A lot of customization is possible. The third session is on eHealth 1, chaired by Dr. Indrajit Bhattacharya and Dr. Sanjeev Sood. They noted that Sathi has started a project for telemedicine-based limb care in Goa and coastal Maharashtra, as well as parallel counseling center at Aiims. A telephonic project has been started at Mizoram under the National Program for Control for Blindness, where ophthalmic assistance in rural areas will decrease the need to travel to the city for eye surgery from 3 to 4 trips to 1. The fourth session is on EHR 1, chaired by Dr. Hardeep Singh and Dr. Pramod Jacob. They noted good discussion of teamwork between IT and physicians for EHR development, measurement of quality through EHRs, adoption of e-prescribing and attitudes and perceptions of technology among practitioners in New Delhi. The fifth session was on image processing PACS, chaired by Dr. Supten. He noted that the assorted session showed good medical image processing. There is potential between various technologies and healthcare institutes across different geographical locations to collaborate. Major area for improvement on all these papers would be a closer multidisciplinary interaction and trying to understand each other's language more deeply. The sixth session is on bioinformatics, chaired by Dr. Kamal Kishore and Dr. Paneet Kaur. They noted comments on two papers, current perspective and gene therapy, and the role played by medical informatics. These were the two papers. The papers showed a detailed literature survey about prospective gene therapy in various medical disorders. This topic is of immense value and has a future potential. On another paper, that is evaluation and monitoring of meta-analysis in medical research through information technology, they noted that the paper provides an overview of the significance of meta-analysis software. The seventh session on robotic engineering, chairperson by Professor Vikram Rath and Mr. Vinay Pandey, noted that the quality of presentation, communication and satisfaction level of question and answers was very good. And papers number 2 and 3 in their session showed innovativeness in their work. Now I'll be talking about the present day, that is today. Seminar on EHR and socio-technical models, chaired by Dr. B.S. Bedi. A socio-technical approach is needed for facilitating healthcare reform initiatives in India. We discussed the use of an 8-dimensional socio-technical model in evaluation of HIT initiatives in the US. We then discussed the application of this model in HIT initiatives in both private and public health sectors in India. The session HIS Public Data Mining, chaired by Dr. Karanvir Singh and Mr. S.M. Raghukumar, noted that HIS and MEMR implementation need extensive change, management planning and training. Innovative models of training were presented. The role of data mining and business intelligence in healthcare was emphasized. Studies on user perception of HIS and EMR indicated that users were initially uncomfortable but soon learned how to use the technology, especially younger users. Session on eHealth 2, chaired by Dr. Denham and Dr. Saurabh Bhatia. Noted, we saw what the technology promises to bring in the next few years, right from independent monitoring networks to a personalized health record book. Session on health provision, chaired by Dr. S.B Gogia and Dr. G.D. Mugli. noted that it is a miscellaneous group of papers talking about healthcare delivery through IT. 2 papers talked about the concepts of M-Health and IT-based healthcare in future. Another paper talked about Pyramid E-Swasthalaya, which is providing rural healthcare through a range of services including M-Health. Session on EHR2 that was chaired by Dr. Dean Sitting. Various health information technologies are being developed and implemented across India. Knowledge management, these include knowledge management, personal health management, and open source software under cloud computing. With this, I end the summary of the presentations. And I would like to invite Dr. Gogia to add on anything else which I might have left. Thank you.
Because any concept there have to be learnings which have to be done. Most of the time it used to be that you think of it at the end. You wanted it live. At that time you remember what is going on. So unfortunately, because it's so tight, we could not put it on a proper set of slides, but that's what we plan to do and put it on the website so that all IMM members and anyone can go through some learnings which we have got from the conference. That is the idea. One of the things that which have been left behind more because this thing we thought of a little later and the conference actually started a day before. So there are no learnings from the workshop. Of course, workshop is supposed to be a workshop and we are supposed to learn right there and then. But the actual conference started and there were 2 talks after the inauguration. One was by Dr. S.B Bedi and I just would like to give some learnings from that. Of course, Dr. S.B Bedi has been doing tremendous work in standardization in India right from 2002 onwards, and he gave a very nice summary of the work done and some idea of what the future can behold. Along with that, there was an online presentation by Anne Seder where she, to our surprise, told us as to what is the healthcare situation. She had taken data from various sources from the website and he compared Indian healthcare scenario with Uganda, Cuba. We had seen her previously doing her work in Cuba, based on the Cuba healthcare program, and she gave us some learnings on how we could evolve a healthcare modeling using the virtual networks. And along with that, so that's an addition to what you're saying. And now with the permission of the President, I would have the proud privilege of giving some amount of the marks which all the judges had done for the thing. And I was just totaling all the results just now. And each session yesterday definitely had 2 chairpersons each, so we had got a little more varied opinions. Today the opinions were a little maybe our mistake that even if there were 2 judges in that this thing, I thought Paul is not coming, so I gave only 1 form. So we didn't get 2 sets of opinions for all the papers. But we have had some very good responses, and we did a marking on the basis of 10 marks, which he has already said, going up to 10 marks for various parts of the presentation with a total of 50. And so for the people, the sessions which had 2 judges, we have averaged the score of the 2 sessions. And overall, it's the range of marking has varied between the speakers also, so it's very difficult to judge whether it's actually, because it's individual judges' choice. Some may be tight marking, some will lose marking, so it's nothing to do with the quality of the presentation. Overall, I just announced the results. There are 4 people who have crossed 40, and all of them are worth of a mention. The first one is Dr. Malaviya for his talk on, he's not here of course, but he had given a talk on the target approach to rheumatoid arthritis. Number 2 is Mr. Ganesh Purushottam, who is also not here now, he's left. His talk was on the survey of IT workers in Delhi. Number 3 is Aditya Sood and Neha Arora, I was chairperson for that. She's here, I think. So she was mentioned. And number 4 is Saurabh Bhatia. So there are 2 things, and there's the poster session also, because again, there have been a range of people who are deciding the posters. So there can be variations. Again, we can't really comment. So final 2 posters we have marked out as really remarkable and which were really worth. One is of course by Derek Traitman, on I don't know the words, I'll just read out the title. It's still up there, and one is by, related to the last poster, Performance Metrics Indicator of Supervision, a study of community health workers. And that's a wonderful poster and appreciated. And the second number is by, no, it's not there in the list at all, so I can't even name him. Because it's even he put in later, so we can't judge him because he was not there. That was the later entry. I think this one by Ashu. So we can't do that. Okay, so that completes the performance, and now I will ask Mr. Sushil Meher for his final comments and vote of thanks, whatever. Since the direct treatment, the person on the direct treatment team here, yeah, if you're here, at least we can give you a memento for your prize because the other two people are not here, Yeah. Can you give them a prize, please, for the poster?
Excuse me, sir. Thank you.
Dr. Anil, they have worked very, very hard with me. And my assistant, Mr. Ashu, he also deserves some memento, I think so here also, because he has put a lot of efforts for this event. So I asked Mr. Ashu to take this appreciation award from us, from Dr. Gogia. See, this guy has worked for nearly 12 hours a day for this conference for last 4 months. So most of you, when you make a call, he's replying your email. Most of the times he's attending your phone. And we get a good amount of papers, but when found, no, we are not receiving papers, as well as the number of papers is very less. So we have extended the date. When we have extended the date, we have got a lot of response. And we have to work very hard to evaluate the paper and put in the proceedings. Anyway, I think so everything is in order. Thanks for coming to NCMI. Take that it from there. Thank you once again to participating in NCMI. Thank you to the scientific committee. They have given a lot of efforts to evaluate the paper. Thank you to the thank you those who have chaired the sessions. A lot of support to organize this conference. And at the end, again, I am thank you to my director, the administration who has allowed me to host this conference here. And at the end, again, thanks for those who have assisted with us, but I was able to mention their name to help me to organize this conference. Thank you.
Well, there should be a standing ovation for Mr. Sushil Meher and the
Bye and see you once again. Just one more thanks.